Okay, thank you everyone so much for joining us today, and apologies for those of you that joined at 9. As noted, there was the program that we had the correct times, but that we also noticed as soon as we saw so many people on at 9 that we had left an old thing, I think, that was sort of saying 9 o'clock. So sorry about that. I hope that didn't cause anyone any inconvenience, and that was okay. Yet delighted to have so many people here today, and we're delighted with the panels of speakers that we've got as well. Thank you so much all for joining us. So this event, the idea, we hope, is to bring together a whole range of people really interested in perinatal mental health and the well-being of new parents, both academics, a range of different sort of practitioners in different areas, and others as well. And the event, as you might know, forms the final event as part of a project that's being led by myself and Ranjana Das, who's just put on her screen now, and we're sort of calling it for short sort of Surrey Perinatal, the Surrey Perinatal Project, which is a partnership with the Institute of Health Visiting and the National Childbirth Trust, which is kind of bringing really some research, a range of research really that we've been doing on mothers and fathers and the perinatal period into practice, to try and sort of improve various things for parents, to speak to a whole range of practitioners, to produce resources and various other things. We'll be telling you a lot more about that in the third session of the event, and we'll also have speakers from the NCT and the IHV too. But we're delighted that we've also been able to sort of get together a range of other speakers, some academics, some practitioners, some volunteers, but they're doing various different things relating to perinatal mental health. And so we're really delighted about that and really looking forward to it all. As noted in the chat, I think everyone's already doing this. Everyone's so used to this now. Please do keep microphones muted if you're not speaking during the sessions. Please do, though, if you have questions or comments as we're going through, please do put those in the chat to everyone. It'd be great to get some sort of good comments going on in there. And towards the end of each session, we'll have a little bit of time, hopefully, to sort of maybe pick out a few of those and put those to the speakers at the end. And yeah, I think that's all that I need to sort of cover right now. We've put in the chat details about tweeting. There's also in the chat the full program for the event if you want to see that with various sort of speaker details and so on too. Okay, so we can then continue with the first session of the day, the first panel. And the first panel is called Recovering and Learning from COVID-19 Challenges for Perinatal Research and Support. And our first speaker, we're delighted to have with us Catherine Twamley from University College London. Over to you, Catherine.
Great. Thank you very much, Paul and Ranjana, for giving me an opportunity to speak about our project today. I know we're rather limited on time, so I'll just zip on. So yes, I'm going to be talking about the FACT COVID project. And the first thing I just wanted to point out briefly was that this is part of a consortium of 10 studies across 10 different countries, which we're leading from UCL. And you can see the list of countries here. We're all using the same methods. We all have the same research questions and so on and so forth. I'm happy to answer any questions about that afterwards. So the FACT COVID project, really what we're trying to do is to understand what it's like for families during the pandemic. And our main objectives were to understand why do different people react to measures put in place in different ways? What is about their circumstances that constrain or enable particular behaviors? And this is about thinking about some of the inequalities that we've seen around the virus outcomes and mental health and various different experiences of the pandemic. And then what is the impact on everyday life? So how does living through a pandemic shape everyday family life, education, work, and intimate relationships? So the actual experience of the virus and living through the pandemic, as well as the social distancing measures. And then how can our research inform efforts to support families? So in terms of the research methods, it's a mixed methods, though, largely qualitative longitudinal study, so over a long period of time. We're using multimodal diaries, which I'll explain in a moment, and interviews. Data collection only recently finished. It's been for more than a year, at least in the UK. Some of the other countries did slightly shorter data collection. And we focused on families with children. That's our particular research interest, but also we felt that they would have particular challenges that we wanted to explore and understand. And everyone who was aged 12 years and upwards were invited to individually participate, but parents were also asked to talk about their experiences of the children. So to get on to the challenges of doing research during a pandemic, as you can see, we started very early. We actually started the project in April, and it took us about a month to get ethics approval, and then we got funding after. So it was really kind of fast, and we've been adapting things and responding to the pandemic and the situation and our research participants as time has gone on. But first and foremost, the number one challenge was hardship of participants and to a certain extent the researchers, seeking a diverse sample, switching to online research, and speed in funding. So I'm speeding through these, but I'll go into more detail now. So our participants, like everybody basically, has had exceptional challenges which they have been going through during the pandemic. But I highlight some here. Mental health. So some of our participants had underlying mental health issues, but some were experiencing mental ill health for the first time in their lives, and they really associated this with the pandemic. I have a quote here from Elderberry Mum, who is a single mother of 3 children on universal credit. And she talks about how she had postnatal depression. So her 3rd child was born just a month before lockdown. And she says in this quote, "As soon as I get back from the outside, if I feel itchy in my nose, I started feeling paranoid as if something has happened to me. Then I started crying. I'm always tearful." We also had participants who had illness, who thought they might have COVID in the beginning. They didn't know. Later on, people could get tests. People who had family and friends who died from COVID-19. We also noticed that our families who had children, or indeed parents themselves with special educational needs, went through particular challenges. Here we have a quote from Holly Mum, for example, who says she hasn't been shopping for 4 months now. She would have been reporting this 4 months after the start of lockdown. "I can't go at all because if I go, I have to take her son, who's an 8-year-old with autism, and there's no way I can say, don't touch this and that. So we're like a prisoner in our own house." Holly Mum lived in a small apartment. We had other participants who lived in very restricted, like 1-bedroom apartments with, 4 kids and 2 parents, and that also took its toll. And then, of course, everyone was negotiating risks and kind of the challenge of it's kind of almost, difficult to remember now because we're so used to many of these things. But in the beginning, it was really like shock and dealing with wow. And this last quote is from Zenobia Dad, who very wealthy family, but fairly recent immigrants to the UK, so not a lot of social capital. And he says here, "We sterilize all groceries." This was right up until the very end of our data collection, "or anything that comes into the house. It feels a bit paranoid, but we just didn't want to take any chances because we're so worried that if we do get sick and if we react badly, then we would really worry about what's going to happen to their 2-year-old son." I mentioned briefly the hardship of the researchers. Really wasn't on the same level as some of our participants, but myself and my co-I, Charlotte Faircloth, had 2 small children. So we were also dealing with that, having no childcare for the first lockdown, and the 3rd lockdown also having very limited childcare, and kind of trying to juggle work and a new project was a challenge. So we really were focusing on inequalities in our project. We wanted to understand both within household and across household differences and try and unpack those. At the same time, inequalities were associated with greater hardship. So there was a kind of an ethical issue around that. We immediately, when we started doing the data collection and the recruitment, we had the middle class and well-off families volunteering to participate. But we really wanted those families who were on lower incomes and minority ethnic families. And so there was a real kind of like, how do we justify this? And, you know, I suppose part of the way that we've justified it is that our objectives and our aims of trying to help these families and try and understand the inequalities. But we also got funding for a little bit late after we started our study to give incentives, and the incentives really did drive up our recruitment for families on lower incomes. And we also adapted our methods. So we diversified the kinds of ways in which different families could participate in the study. So more lower income families tended to choose to participate via interviews only. Whereas higher income families, it's not across the board, but higher income families tended to choose to participate via the diaries, and sometimes diaries and interviews. They had more time, they had more smart devices, and so on. So moving to switching to online research, obviously all researchers basically had to do this. We weren't able to do the tried and tested methods that we were used to. Both myself and Charlotte are traditionally use ethnography, and Humera uses very in-depth qualitative methods. So we approached Indemo. As I said in the beginning, we didn't have funding, and they actually gave us the use of the app across the 10 countries pro bono. This was really just kind of an amazing tool, I have to say. And the way it works is the participant downloads an app, so they must have a smart device. So for some people, we bought them a smart device and gave them Wi-Fi credit, and we would give them tasks on it. Sometimes these tasks were what we call flash tasks, and this is an example of a flash task. So we said, you may have seen the news yesterday that the Chancellor, Rishi Sunak, announced a summer budget. The key points can be found here. Can you tell us what you think of it, and will it change your behavior? So this was really kind of immediate methods, which actually isn't really possible so much in traditional research methods, except potentially participant observation. But this was possible with all of our participants immediately. So they would all immediately, we had 72 individuals would get this, although 52 were participating in the diaries. But it was also reflexive and responsive. So here it's very small to see, but we had a question about divisions of domestic labor. And Jasmine, mum, says, I'm happy with how the housework is divided. I wish the house could stay tidy for longer, but basically I'm fine. And I responded and said, well, do you ever discuss the division of housework? I think this is a little bit unusual, your response in comparison to others. And then she really shifts and she starts talking a lot more about how actually she finds it very kind of distressing and upsetting. And it is something that she isn't very happy about. So that just sort of shows you kind of how we could kind of probe and get more depth and from our participants. So that's kind of a whirlwind. I don't know how long I've been talking, but I'm always cut off when I have a 10-minute presentation. These are my colleagues, Humera Iqbal, Charlotte Fairclough, myself, and then an RA, Nicola Carroll, which is funded by the British Academy. Happy to answer any questions.
Thank you so much, Catherine, and that was amazing timing, absolutely spot on. Thanks so much. Brilliant. Okay, so our next speaker, we are delighted to have Amy Dignam, who is from the Maternity Voices Partnership. Welcome, Amy.
Hi, Paul. Hello, everybody. Thank you so much for inviting me here today. I've actually don't have a presentation. I was at birth for 26 hours, so it'll be just me talking you through the work that I've been doing. So just a few words to introduce myself. I always find this bit a little bit difficult because I actually wear so many hats and the presentation can be quite long and overwhelming, but just in a nutshell, if I manage. My name is Amy Dignam. I'm the mother of 3 children. I'm an artist, a birth activist. I'm an hypnobirthing teacher and birth doula. I run an art organization that supports self-identified women artists with caring responsibilities. I am one of the founding mothers of a project called Maternal Journal. I am the co-founder of another project called Play the Race Card, which I will be talking a little bit about it shortly. And I'm co-chairing the Maternity Voices Partnership at Chelsea and Westminster and West Middlesex Hospital. So today I'm going to introduce you to some of the work I have personally been doing during the pandemic to improve maternity care services in terms of inclusivity, but also how the MVP work together, ensuring that all voices are always heard and taken into consideration and validated. So first of all, the Maternity Voices Partnership usually is chaired by a layperson. In our case, it's 3 people, Sarah Espenan, Zena Barry, and myself. We are all from different backgrounds and cultures, and this provides a means of drawing on a full range of different skills, abilities, and education and experiences. And in this group, service users, providers, and others come together to collect feedback and co-produce services and ensure that all women, birthing people, and families are at the center of all the work that it's done. During the pandemic, we were faced with an overwhelming amount of unexpected new challenges. We had to quickly adapt to this new reality like everybody else. And so we built a more robust support network for our service users. We actively worked with the Trust on producing helpful information to keep our service user up to date with all that was happening, as women found themselves having to go through a very vulnerable time of their lives on their own, having to advocate for themselves and sometimes birth by themselves. And it's the pandemic that really highlighted more than ever the disparity in healthcare provided to Black and brown women and other minority groups. So as you gather from my introduction, I do a little bit of research and work with different groups on different projects. And that in turn informs the work that I do with the MVP. And in recent times, I've been really busy in understanding and addressing issues of inclusivity within the maternity discourse. It is very challenging to move away from binary thinking and what we've always known and interrupt our natural thinking process. It's much easier to just stick to what we know. So it took me a lot of learning, a lot of keeping quiet in a way and practice good listening to even only just begin to understand these concerns and this reality. Doula and educator Mars Lord once said, we need to learn to be culturally humble. And I think this is what I've been trying to do, whilst understanding that this is not about me, it's not about how sorry or worried I feel, and that the best thing I can do is to give space, to sit back, to sit in my own discomfort of being a white privileged person and just listen and really listen and learn. So the many conversation that we've been having within the Maternity Voices group revolved around race and gender, which is where my talk is kind of focusing today. So these 2 groups in particular are frequently victims of violence and abuse and other forms of discriminations. And as we all know, Black and brown women are 4 times more likely to die during birth and up to a year after giving birth than their white counterparts. Whilst the LGBTQ plus community often don't even access healthcare at all and have a high rate of mental illness, including suicide, because they feel they have no support. They are afraid of seeking support. They feel alone, and they do not see a system that includes their voices and their realities. We are not all the same. Considering the person in front of you in their individuality really creates a positive change, and people are individual and deserve individual care. And I think this is where it was a bit of a starting point for us. Something we hear a lot is, I treat everyone the same, regardless of the color of the skin or their gender. But we found this is problematic in itself, as we are, like I said, not all the same. And by not seeing color or not taking into consideration a person's gender, we are only erasing or ignoring part of those people, a very important part of those people that we cannot ignore in life and when we care for them. So my work has been mainly focusing in raising awareness, becoming hopefully a good ally, not by taking central stage, but by offering my support from behind the curtains. I by no means have been appointed myself to be a spokeswoman for this group. I do not represent this group. I'm just someone who cares about pregnant women and birthing people, health and rights, and someone who has 3 children that are growing up in a world that undeniably needs some fixing and some reconditioning. So being here today and talking about these issues is not easy, because as a white cis woman, I feel my privileged position, and like I said, I usually just work from behind the curtains, but it's important to hear from the real voices. It's important to expand groups and gathering and panels and design them and structure them to elevate those marginalized voices. So for example, at Chelsea and Westminster, we are running a series of listening events that followed an ethnicity and maternity care survey, where we aim at giving a safe space to different minority groups to come and talk and share their experiences, whilst it's a chance for us to really be listening and understanding about what part of the service works and what instead needs improving. We have a safety champion team as well, where all these topics get addressed regularly. We have a very diverse panel of people that attend our MVP quarterly meetings. We invite and encourage diversity within the panel without, fear of not understanding. If we don't understand, we put our hand up and ask, but we also do our own study, as it's important not to ask people something we can learn ourselves. So we're willing to learn, and learning doesn't happen quickly. It's a journey. We have several ongoing conversations, one of which is about language and how it is important to include everybody in the picture. We all know that language in maternity is important. We moved from using the term delivery, for example, to birthing, and this happened with a simple shift and by listening to service user feedback. So it's not impossible to start including terms like birthing person to go alongside pregnant woman, chest feeding, which is a term preferred by trans men, alongside the general term of breastfeeding. So inclusion rather than erasure is the way forward. And like I say to my children all the time, the sun is big enough for everyone. And gender fluid and trans issues are much more widely discussed and visible now. And what I do is simply taking some time to connect with people through blogs, websites, organization, as well as talking to people in real life. And I just wanted to quote something that my friend and colleagues, birth activist and midwife, Laura Godfrey-Isaac, wrote. She said, within the maternity service, it is our professional responsibility to inform ourselves and act respectfully towards people who have different identities and ensure they have access to healthcare without discrimination or abuse. Another project I work on during the pandemic is called Play the Race Cards. So parallel to the pandemic happening, the Embrace published a report on Black and Brown women maternal mortality. This report not only provided statistics, but also short summaries on the circumstances in which some of these women died. It was a harrowing read, not only because behind every statistic there is a real woman or person, but also because of the patterns that it showed, suggesting endemic problems in our maternity system. Since then, I attended many mentions, talks, webinars, cultural safety training. I started following activists on Twitter, only until one day I was at the Black Mum Magic Project event, where Black women were invited to talk about their maternal experiences. And I heard this woman, Amma McKinley Ballantyne, talk. I didn't know who she was, but I felt connected to her and I felt completely absorbed by her words. And I thought she spoke so beautifully. She was explaining the ordeal she had to go through during her miscarriage during the pandemic, how she was not listened to, how she felt nobody supported her. And I suddenly had an idea and I wanted to share it with her, and I wanted to ask her to be the voice of the project that I had in mind. So I sent her a private message and I asked her for her phone number. And the idea was to create a set of 10 affirmation cards designed for midwives and healthcare professionals to help them reflect about their decisions, and remind them of the unconscious bias that we all hold, because internal unconscious bias show without us knowing that it's showing. So she was really happy, and she got on board, and very soon we start working with two amazing women powerhouses, Mars Lord and Nicola Madia Goodall. So the cards wanted to create a change. They are aimed at changing the way we are working, the way we are thinking, and ultimately improve the outcomes that we are having for the Black and brown bodied people. These are the cards. Sorry, I don't have them on a PowerPoint. But it's a simple resource to remind us about the people in front of us. They remind us to do what we were taught as children when it came to road safety, to stop, to look, to listen. And we also included a remember. So with the card, we were saying, consider your internal biases, consider how this woman person might be feeling, ask questions about the traditional cultural practices, introduce yourself properly. What tone of voice are you using? Take the time to really hear the questions, reassure them. Have you learned about how different skins present symptoms? And if you're not sure, have you checked with your body? Is the person in a risk category? And remember that they trust you. So these were some of the reminders we worked on, because every person has the right to give birth with grace and dignity, and be respected and listened to, and their feelings and experience validated. So hopefully with this card, we are encouraging healthcare professionals to pause and reflect and reframe what they are doing. And I think my 10 minutes is up. So if you want to know more about any of the work I do, please feel free to get in touch. And many thanks again for having me today.
Thanks so much, Amy. That was fantastic. Our final speaker is Pooja Patel, and she's from Acacia Family Support. Over to you, Pooja.
Hi, thank you for having me today. Thank you, Amy. That was really insightful. And like Amy, I don't have slides, so I'm just going to speak about the various projects that have been going on over the last year. Again, I have a few hats. So by profession, I'm a health psychologist, and I work two jobs, one within perinatal services and one within public health training and consultancy. But today, really, I'm going to just talk about an overview of some of the work we've done at Acacia and my role within that, and a project that we co-founded, myself and my colleague Tina, called Another Mother's Story, over the first lockdown. So Acacia Family Support is a perinatal charity in Birmingham, and my role is the specialist cultural and race project coordinator. And I have been fortunate to work on various different projects that support Black, Asian and minority ethnic women across Birmingham. So pre-pandemic, a lot of my role was outreach work. I was very rarely in the office. I was always sort of in same playgroups, community centres, schools, education amongst educational groups, really raising awareness and understanding, really raising awareness around what perinatal mental health was. And when I first went out to do my first group, my first workshop with a group of Pakistani women, I very quickly realized that actually I need to scrap my whole workshop, because what they wanted was just for me to sit there and listen to their stories and experiences. And that was really my first sort of kind of moment where I thought, actually, what I'm doing is trying to fix situations. I'm not here to fix situations or solutions. I'm here to listen. And that really kind of changed my whole outlook around supporting women from different backgrounds. And sort of similar to Amy, listening is a crucial skill when you're working with women on the ground. and really trying to understand their cultural background, their cultural heritage. And actually, Birmingham is predominantly South Asian. So there was a lot of groups that I was working with which were South Asian women. And what I was finding was there's actually a lot to celebrate amongst our community as well when it comes to birthing practices. There's a lot of wisdom in our elders' words, which we often take for granted. And so that kind of started to change my mindset and my frame of thinking of how to work with South Asian women in particular, being from that background myself. And then obviously the pandemic happened and everything stopped. All outreach work stopped. It was all telephone support, very different to what I was doing on a day-to-day basis, not something I was used to at all. And again, I was supporting a lot of South Asian women on the telephone purely because of language needs. And it was difficult. It was really difficult because, you know, people are living within extended families. There's a lot of stigma around perinatal mental health in itself. And, you know, a lot of women were coming to our centres or coming to the workshops as a way of respite, as a way of kind of getting out of the house. But now these women are confined between their four walls and pretending that they were speaking to their health visitor on the phone. So there was a lot of challenges and a lot of issues, and I was frantically looking for research or any resources that would help me to support them. And as I was sort of looking, it occurred to me that the stories of South Asian women during their mothering journeys are very rarely documented. We see a lot of papers based around white British mothers. Books and literature is very much around that too. And there was sort of nothing that I could access that was valuable or that was relevant, that really kind of captured the authentic experiences of South Asian women during this perinatal journey. And it was that day, this is kind of back in April last year, I reached out to a colleague, Tina Mystery, who's a clinical psychologist, and we spoke till 1 o'clock in the morning that day over Zoom. And as you can imagine, our eyes were completely bloodshot red from being on the screen. But what we kind of wanted to do was create a platform that celebrates and challenges the issues of South Asian mothers that they may experience. So from the point of conception, fertility, infertility stories, mothers with disabilities, children with additional needs. We wanted to really capture those stories, including obviously the overarching aim was maternal mental health, because these stories are very rarely documented anywhere. And actually what we thought was, if we create a platform where we can capture these stories, they will be there for life. Anyone can access them. That could be used for research, that we can find the overarching themes, etc. So it started off as a very basic kind of idea. And then we thought, well, why not publish these stories? We approached a publishing house and they really liked the idea. So we are now publishing our first anthology next year with a publishing house, Sattva Press, who really encouraged us actually to say, don't just capture these stories, do your own research, go out there, do a bit more research, write your own reflection, perspectives, etc. within this book. So the first kind of thing we did was put a call out for anyone who was, any South Asian women who were interested in writing around their motherhood journeys. Simple Instagram post, we got like over 50 people message us. We were a little bit overwhelmed, and now we do have 25 writers who have written their pieces in such a beautiful way, which captures their crisis, struggle and resolution. And these are stories from single parenthood, domestic abuse, maternal mental health issues, mothers with cancer. So we've captured these stories, and from that, we are now creating a series of podcasts. But what we really wanted to do was actually just highlight that these are often othered women. The whole concept behind Another Mother's Story was that often Black and brown women are othered, but actually we want to provide another perspective, hence the title, Another Mother's Story. We wanted to capture the celebratory side, so the cultural traditions and practices that we kind of would see amongst a typical South Asian family when a baby is born. We wanted to understand healing and traditional practices through fertility journeys. So we're really trying to capture these authentic perspectives that we often don't hear in the mainstream. Since then, we've really expanded. We hold once monthly writers groups virtually. So that is led by a South Asian woman, and it is all centered around South Asian motherhood to really capture those celebratory kind of moments. So in that, we have around 30 women attend every month. And what we saw was actually, this is a sustainable model that we can kind of take a step back from. And these women are leading these groups now every month. And what we actually saw was that they were creating discussions around particular topics that affect a South Asian woman. So what is perinatal mental health? And we'll give them the resources and they will discuss that in this writers group. What is loss? What does loss feel like? Infant loss, for example. What does grief feel like? So it's a sustainable model that we've tried to create. In fact, we haven't tried to create, it's sort of just happened. And a year down the line, we're now creating a series of podcasts to capture their stories in another format. So that's kind of where we are at the moment with Another Mother's Story. And just going back to Acacia Family Support, we kind of have various different projects on the go. One of them at the moment is we're creating short films in various different languages that explain what perinatal mental health is, that explain what the signs and symptoms are of perinatal mental health, and that actually capture the cultural aspects of a woman's journey as well. And we felt that bit was really important to capture that essence of cultural challenges and celebrations during that woman's journey. So there's a few things that are going on, but my passion has always been to support South Asian women during this particular period, from a personal perspective, from stuff that I've seen, from working on the ground with them, and really reframe that often we're seen as these oppressed women. We're not. We have a lot to celebrate. There's a lot of resilience in a lot of these women's journeys, and we really want to capture those authentic experiences. So we are publishing the book this time next year, which will hopefully inform training and future research as well. I think I've kind of covered everything I wanted to, but I'm happy to take questions as well. And yeah, thank you again for letting me speak.
Thank you so much, Pooja. That was really powerful and really valuable. Thank you. Thanks to all the speakers. We've had a few sort of comments sort of coming through. There was a lot of interest in the methods in Catherine's study. One question, we'd be keen to hear more about how participants reacted in general to the diary keeping tasks and so on over above the interview. So sort of, if you'd like to say a little bit more about that, Catherine, like how did people respond? Did you find, were there any sort of hitches or issues, or did it actually run sort of fairly smoothly from the start?
Well, I can't, combination. So some people were super enthusiastic. Women were more enthusiastic than men. So in general, women participated more regularly than men, which at the end made understanding gender differences a little bit problematic, because, you know, you would say maybe men didn't really talk about this, so maybe it wasn't an issue for them, but then men talked less in general, so sometimes it was hard to make those kind of generalizations. We were very intensive in the first few months. So we had tasks coming up, you know, twice weekly, and tasks was the language of the app, otherwise we wouldn't have chosen that. I'd say the feedback at the end of the year, particularly from the diary keepers, was that they really enjoyed the process of keeping a diary, even those that weren't very regular in the diary keeping, because it gave them a space to reflect on this kind of historical moment as they saw it. And a lot of them asked for the data that they had uploaded onto the app to be downloaded, and so that they could kind of keep it as a memento, remembering back on the time, even those who really had kind of difficult experiences. Some of them did tell us, and we kind of stepped back, that they found it quite overwhelming in the beginning. So then we reduced how often we uploaded tasks. But essentially it was, you know, it was broadly speaking positive, but we were, because of, you know, the ethical issues, we were very kind of like, you don't have to respond to this, you know, if you don't want to, and so on. So I think people felt in control, and they did, you know, just not respond when they didn't feel up to it, and they could come back to things. The flash tasks would have a short life. So if we did a flash task, say around Black Lives Matter, we did a flash task, within 2 weeks, it would disappear. So if they didn't answer it within that two-week period, they would no longer have the opportunity to answer it. And some of them, like, where are you getting your information about the pandemic, was there, and they could return to that and update it and respond to it and discuss it again. So
brilliant, thank you. Also, yeah, a few sort of really positive comments about all the speakers. Somebody saying, thank you, Amy, really insightful, and the term culturally humble will stay with me as a sort of a sort of principle, really, and a way of sort of understanding things. For Pooja, we just had sort of brilliant presentation, a few other sort of really positive comments there. One thing I wondered whether it might be worth sort of discussing more was, I suppose, how you approach the challenge of sort of accessing sometimes groups that are less sort of keen to engage, that perhaps feel that services aren't particularly for them. And I suppose maybe an extension to that is how you managed to do that, or whether you felt that you managed to do that during the pandemic when things were sort of especially sort of difficult. I don't know whether sort of maybe Amy and Pooja both might want to comment on that.
Yeah, sure, Paul. You know, this is something that gets asked all the time, and something that we've been talking about quite a lot, because, you know, some of these groups that we try to talk to and engage with perhaps don't have phone or internet connection, or, you know, so a lot of things obviously moved online with the pandemic. So it has always been at the front of our worries, how can we access these groups? And it's been a real challenge. I think some of the work that we did was trying to connect with local organizations that were able to support these people, so that we could kind of get to them through these groups. And also within the trust, we did a lot of work when people were on site. So we would have, for example, with the survey, the ethnicity maternity care survey, we had paper version of it. We had midwives on a labour ward and the birth centre going around with their own iPads, asking, could you please do these surveys for us so we can understand where we are at. So it's been very difficult, but these are some of the things that we've been doing, mainly trying to reach out through local organizations and local support.
Thank you. Yeah, that makes a lot of sense. Yeah, Pooja?
Yeah, just to add on to that, again, local organisations are key. and being creative in how you reach out to people. We're often quite, as health professionals, we often think, yeah, here's a form, let's give it out to everyone and hope that we'll get some response back. But actually just sitting with a community group is so much more valuable, and developing connections that way. And you know, most people have access to WhatsApp or a phone. So just creating, you know, we created a really small like flyer that kind of just got circulated. So it's just about getting creative, and people aren't hard to reach. They're just sometimes easier to ignore. And that's something that I've learned. Yeah, so it's just finding out what the community wants.
I just wanted to add to that, sorry, I just remembered that the hospital was able to give us a heat map. So we could see where the population was concentrated around the map. So we were able to kind of concentrate on a specific site rather than another. And I think that really helped us as well to be able to really see, locate where these communities were.
Thank you so much to all of you. That was a really valuable, insightful, inspiring first session. Thank you. And now I'm going to hand over to Ranjana, who's going to get us going with the second panel.
Thank you so much. And in so many ways, I think the second panel really sort of dovetails nicely with the first panel, because some of those issues that we've been sort of hearing about in terms of the pandemic impact on things, and also sort of developing services that are more inclusive and more diverse. These sorts of themes carry on to the second panel with a particular focus on something that we heard from Pooja, for instance, about, which is sort of using creativity and also the use of technologies and digital services in some ways within perinatal care. And again, we have a mix of academic and non-academic participants on this panel. So we are going to now look very closely at people who've either researched the use of digital technologies or who have sort of produced creative or digital products in relation to perinatal well-being. So our first speaker on the panel is Jane Fisher, who wears many hats and is a mental health nurse lecturer at the University of Central Lancashire, and is the author of a fantastic book, The Sun Will Shine Again. So over to you, Jane.
Hi, Ranjana. Thank you for that lovely introduction there. It's a pleasure to be here this morning talking to you. Thanks so much for having me. So my name's Jane. First and foremost, I'm a mum to 3 children, Faith, Joshua and Bella. I'm also a mental health nurse by background. Spent 15 years working in a variety of mental health settings, and currently work as a mental health nurse lecturer at UCLan here in Preston. I'm also someone who lives with quite significant mental health challenges at times, and that began with perinatal mental health problems after my youngest daughter, Bella, was born. So when Bella was born, I quite dramatically and also quite traumatically went from being a mental health nurse to a mental health patient virtually overnight. And that has been my journey for the last 6 years, where I've been most of the time simultaneously a nurse and a lecturer, or a mental health patient, whilst also being a mental health patient. When I experienced perinatal mental illness, my whole life seemed to fall apart, as did that of my husband and our children as well. Things were incredibly difficult for that first year of Bella's life. I had 2 older children at the time, and as a mental health nurse, I was all too aware of the need to to try and explain to my older children, particularly my older daughter, what was happening to mummy, and why mummy was crying a lot of the time, and why they all had to pile in the car whilst Daddy drove me to an appointment to see a nurse that was going to help mummy's poorly mind. I never wanted me struggling with mental health problems to be something that was hidden, that was a big family secret, or something that was never spoken about or hidden from the children. We wanted to be able to talk about it and be honest with our children, but obviously in an age appropriate way. Now, despite my mental health nurse background, when it came to talking to my own daughter about mummy's poorly mind, I didn't have the words to do that. I didn't know where to start. I didn't know what to say. So those early conversations were kind of driven by my husband, and we essentially said, mummy's mind's poorly at the moment, so mummy needs to get some help. As my children have got older, slightly older, and I've continued to struggle with perinatal mental health, and then after 2 years, you kind of lose the perinatal and just become generically mentally ill, which is quite interesting as well, and has some connotations attached to it that I've not got time to go into today. But I kind of realised that, my mental health, was something that I was, going to be part of our lives for a while. And as I was feeling slightly better, I really wanted to explain to my children what was happening. So as a result of that, the sun will shine again was born, motivated to help me explain to my daughter Faith what was happening with mummy's mind. I worked alongside Amy Dignam, who you heard speak just earlier, and she did some amazing, beautiful illustrations to go alongside the book. And our hope and our passion and our motivation for creating this was to help us talk to our children. I read it with my kids, not last night, but the night before. But we wanted to give a tool to other families. We wanted to support other families to be able to start those conversations with children. So it approaches maternal mental health in that gentle, comforting and age-appropriate way. We try and reassure children that poorly minds don't last forever. We compare poorly minds to poorly bodies to try and normalise mental illness. And we also try and empower children with some knowledge about emotional well-being and self-care. And the little girl in the book has a magical medicine bag that gives children ideas of how to look after their own minds, and how we all need to be looking after our minds. Now, I'm aware that we're on Zoom, and I've forgot everything about Zoom because I'm used to Teams now from working at the university, but I will try and share my screen just to give you a few images from the book. I'm going to assume that you can see the PowerPoint unless I am told otherwise. So that's my daughter Bella when she was born, and that's when my journey kind of started. There's my three very small children there. That's my oldest daughter Faith. She's the little girl that is in the book, and she's my motivation to get this out there, because it wasn't easy. Myself and Amy did a lot of hard work, but that's the cover image to the book. So we're on social media, and I will put the link in the chat as well. But you can purchase the book from the website, or you can send us an email. I'd say the book is generally aimed for under 8 or 8 and under, but as it is a very specific, then it can be used with slightly older children. We've got some copies, working on getting some copies to mother and baby units. We've had some bulk purchases as well from health and social care teams and health visitors, to give health professionals a tool as well. That's the back of the book. As you can see, Amy's illustrations just bring it all to life, and are just so amazing. It was also quite therapeutic for us as well, to be able to use creativity to make sense of our journey and to try and help other people. And then that's just a couple of pages from inside the book, so you can see it's not a textbook. It's really friendly. It's age appropriate. It's a storybook. And there we've got an image of Faith attempting to look after mummy. We talked there that there are lots of kind people to help poorly minds get better as well. I think that's that's the final image that I've got. So thanks so much for listening. This is a real, it's a piece of me in this book. It's a piece of Amy in this book. And if we can, help and support other people, then it kind of makes some of what we've been through, gives a purpose to some of our struggles and our pain, if we can help other children and other families. So thank you for listening.
Thank you so much, Jane. That was really powerful, and what a splendid book. And that sort of an overlap between the sort of carer role and patient role was really, really key in what you talked about. Thank you. Our next speaker, again, like I said, it dovetails in so many ways with the first panel, because we've heard about mothers from migrant communities. And our next speaker, who's joining us from the Sydney Centre for Healthy Societies and the Department of Sociology and Social Policy at the University of Sydney, Leah Williams-Viazzi, works specifically on migration, motherhood, health, and digital cultures. So quite fittingly for this panel on technology. And particularly, she's published her first book, Migrant Mothers in the Digital Age, Emotion and Belonging in Migrant Maternal Online Communities. So really excited to hear about that. Over to you, Leah.
Thank you, Ranjana, and it's really great to be here. And I'm speaking to you today from the land of the Wongal people of the Eora Nation, land which was never ceded. I'm a sociologist at the University of Sydney, as Ranjana said, and I'm also a mother. I'm just going to try and share my screen while I'm talking. Both my children were born in the UK, and shortly after the birth of my second child, we moved to Australia. And I'm going to be talking today about my research on migrant mothers' Facebook groups specifically, so particularly focusing on the experiences of the admins of the groups, and so the labour involved in creating and maintaining those kinds of peer support communities. So the research project, I interviewed 41 migrant mothers living in Melbourne and Sydney, who were the admins or members of Facebook groups specifically for migrant mothers in those places. And 15 of the people that I spoke to had an admin role in the groups. The interviews were conducted in pre-COVID times, but as we know, digital peer support groups have gained even greater salience during periods of restrictions on meeting face-to-face. So they've become even more important, I think. So hopefully that will be still some useful things to gain. So let me go on the next one. So this slide just gives examples of the types of groups that I'm talking about. No, not the specific groups I researched, because otherwise it would compromise the administrator's anonymity. But you can see they've all got kind of 3 elements that set the parameters for the group. You've got the role, so mostly mothers. Some groups did include fathers, but they were mostly mother focused. The location, the suburb or city where they were currently living, and some kind of origin reference, so a place, language, heritage, or culture. And it's important to note that the groups form part of a really varied social media landscape and a varied social landscape more broadly. So participants were usually members of multiple groups, and they were able to draw on them selectively for the support or information that they needed. And we often think about these kind of resources in isolation, but particularly when we're talking about online resources, it's really important to remember that people are often kind of picking and choosing where they're going to go for the particular thing that they might need. And when we're talking about perinatal wellbeing, one of the things that I think is really important to think about is that we can see mothers in relation to each other, so not just in relation to their children or their partner or service providers. And we can think of that in, you know, in kind of offline ways and online ways. And also in the realm of the imaginary. So thinking about the different communities, the different imagined communities that women position themselves within, the ones that shape their decisions that they make and how they feel about those decisions. So, for example, when you're talking about, to give an example from the study, you might kind of think that you are, you know, oh, I'm a Bondi mum. I live in Bondi. I go to these certain places. I use these kind of resources. I wear these kinds of things. So I might join an online group for mothers who live in Sydney's eastern suburbs. But I'm also a German mum, so I might join a mothering forum that's based in Germany. And bringing those things together, I might see myself very much as a German mum in Bondi. So I might join a German Mums in the Eastern Suburbs group. And obviously those things can be quite complex. So, you know, sometimes people were members of more than one group. So for example, we had a couple of British mothers who had Indian heritage. So they were members of a British mothers group, and they were also members of Indian mothers groups and things like that. So it's a lot of complexity, but I think thinking about those imagined communities is really important. And a second thing to bear in mind is that mothers are people too. And that might seem obvious, but one of the challenges of new motherhood can be that your identity can really become subsumed into this kind of maternal identity. And some of the interventions that we think about can focus really on that kind of maternal role. Whereas these peer Facebook groups being created and run by the people who use them are able to respond to a much broader set of needs. So the women that I spoke to talked about using them to find friends, to manage their feelings of homesickness and loneliness, as well as things like relationship issues, or just finding someone who they wanted to speak in their first language with. So you can see this in this quote from Winnie, who's a Malaysian mother who'd moved to Sydney. And she said, you know, even though I don't use them every day, when I need them, they're there. I know where to go if it's something I just want to ask, maybe just something with my culture. You know, I can find people to instantly meet up if I want to meet someone who speaks my language. And I think that's really important, helpful. It makes me feel like I'm home. So the sense of home and belonging was really important. Not just because people were migrants, but also people often felt kind of quite lost in their new kind of maternal role as well. So the sense of home and belonging is really important. Okay. So for the rest of the time, I want to really talk about the labour that goes into creating and running these peer support spaces and the impact on the women who do that work. So I use the term digital community mothering to refer to this labour performed by the administrators of the group. And I frame that labour as a form of kind of horizontal maternal care, so care between mothers. And I'm drawing on the concept of community mothering from African-American feminist scholarship, in which women take on responsibility for the well-being of children, mothers, and families in their community. So the US sociologist Patricia Hill Collins describes women-centered networks of blood mothers and other mothers who provide care to children and mothers in their community. So in this context, though, I'm talking about digital community mothering among migrant mothers in Australia. And that kind of, that really involved providing, so quite direct support to mothers in their community. So providing information and advice, arranging meetups, sharing childcare, kind of stepping in emergency situations, that kind of thing. And it also involved creating and maintaining these community spaces, online community spaces, where mothers can give and receive support and care. So in my research, digital community mothering involves the following kind of key elements. So the group administrators take on a leadership role within the online community, which often spills over into the offline local community. They curate the groups as spaces where mothers can feel safe to discuss how they feel. So they set boundaries about who can join. They set guidelines around norms of behavior. They role model certain behaviors and enforce certain behaviors and norms. And in particular, they intervene to minimize conflict and to embed a norm of compassionate mothering. And I use the term compassionate mothering not to talk about compassion between mother and child, but compassion between mothers. So to denote a norm of approaching mothers who might do things differently to you with empathy and compassion, rather than this kind of common media trope of combative mothering or, mummy wars, that kind of thing, which positions mothers as always in competition with each other over parenting choices. So the admins often refer to other online mothers groups where there was a lot of conflict over maternal practices. What is good mothering? What are the limits of good mothering? But in terms of their groups, they work really, really hard to encourage compassion and recognition of different forms of mothering. And this was particularly important in these migrant groups because they really recognized that members of the group were often navigating really tricky waters of multiple narratives of good mothering, what they'd experienced in their own childhoods or their early mothering experiences overseas if they'd moved with children, what family and friends back home were advising them, what they saw in their local community or media, what they were told by healthcare professionals in different contexts. And the admins themselves, who were also migrant mothers, were really able to deploy the insights that they gained through their own experience, to understand that there are multiple ways to parent and multiple ways to navigate maternal norms. And they were able to deploy that in the way they interacted with the members. So they kind of intervened with empathy to really encourage others to interact in the same way. And you can I've got a couple of quotes here. One is Priya, who's the admin of one of the South Asian mothers groups, and she's talking about conflicts over things like co-sleeping and how you manage that. And she says, instead of kind of publicly saying that co-sleeping is going to cause their baby some harm, maybe do it kind of privately or post a link to some research or something. And she talks about how, she thinks it's insensitive or too direct, she'll pull them up on it. And Jenny was an admin of a Swedish parents group, and she talked about posting. She said, I try to post things I don't agree with sometimes and just go, this is not my personal view, I just want to kind of share it. And she just says, I think it's really important to have a group and see that people do things differently and we can all be friends. So moving on to this kind of idea of maternal leadership, some of the really active admins describe spending many hours a week on running the groups, and they described it as quite exhausting, particularly if they were juggling it around kind of paid work, other community work, relationships, parenting, often, kind of really struggling. And it's interesting, I suppose, talking about the perinatal period, most of the women who were admins had moved through that period a little bit. They were on their second child, for example, and so they'd maybe kind of, got a bit more kind of solid ground to start from. But on the other hand, many of the admins expressed a real sense of pride and achievement in what they'd created. I mentioned earlier some women feeling subsumed by motherhood, especially in the context of migration. So for some women, running a locally based online group really gave them a sense of visibility within their local community, as well as an enhanced, much stronger social network. So Nisha, who was another admin of the same South Asian mothers group, she said, I feel it's a feather in my cap and it's not what it was supposed to be. It was just supposed to be a support group for myself, but the more people I meet, the first thing they say is, oh no, thank you so much. And it means I feel like I'm part of the community because of the group. And I feel like I've done something because of the group. Like I'm actually contributing to the community in a big way. And that makes me feel really, really proud as well. So just moving on to my final kind of concluding points, really, I wanted to just really emphasize that, migrant mothers, not only migrant mothers, but that's my context, migrant mothers can play a vital role in supporting each other using social media. They use Facebook groups to create and access support, information, friendship, belonging, and reassurance. It's important to understand mothers' imagined communities and how this shapes their decision-making, their identity, and their parenting practices. And one of the really important things that came out of it was this idea of kind of leadership. So they can really become these kind of accidental community leaders through what might start as a very small group. Often they just had a couple of friends that they invited, and then it kind of spiraled into these groups that might be hundreds or thousands of members. And I want to leave you just with two questions, really. How can service providers support mothers in creating or using online communities? What tools? Obviously there, for some people it might be second nature to look online, and for others maybe less so. And then the second question is really, how can we avoid these kind of parental peer support exacerbating inequities in gendered labour? So, they're obviously really useful, but given the amount of work involved and the fact that it's, overwhelmingly mothers doing this work, how can we avoid this becoming a kind of a digital second shift alongside paid work and childcare? So I'll just leave you, that's a picture of my book that I'm very proud of. And if you want to connect with me on Twitter, that's where I am on Twitter. So I'll just stop sharing my screen. Stop. There you go.
Thank you so much, Leah. That was excellent. And like you said, you're on Twitter and we've been tweeting about it too. So if you want to put your book link up there, please do so. So kind of taking forward that technology and creativity theme now a bit is, I think, two speakers presenting together today from All Right Mate, many of us who we've seen on social media and Twitter in terms of their participatory art projects that are so fascinating. All Right Mate, we have Callie Hayes and Hugh McCann with us today, and they are going to talk about their participatory art endeavors that sort of normalize conversations about mental health by gathering and sharing sort of stories and real and relatable conversations about male mental health with a diversity of audiences. So over to you, Callie and Hugh.
Oh, thank you so much, and thanks so much for having us. It's been really interesting morning. I'll just share my screen, and unless anyone says, I'll assume it's working. Hopefully it should be the PowerPoint slide you can see. Okay, great. So I'll just do a quick introduction, share some of our work, and then hand over to Callie, who'll talk in a bit more detail about the work that we've specifically made around parenthood, fatherhood, and mental health. But a quick overview is that we're a community interest company who are a couple of years old, and we decided to start making work around male mental health in relation to the statistics around male suicides. And we both have a sort of background in the arts, and we're wondering what might the arts be able to offer in terms of interventions or different ways of looking at the things that might contribute towards these stats. So we've worked with groups, sort of male-dominated communities like veterans, community industry workers, and we've worked with sports teams and just general people. And then we've shared conversations that we've had with those communities back in those community settings through interactive posters that you have links to audio to, theatre pieces that have gone to community spaces, books which have been distributed amongst those communities that were co-written with members of that community. But today we're just going to be talking about the work that we've done around fatherhood and mental health. So I will now move on to a 1 minute or 1.5 minute video, which just showcases a few of the projects we've done around fatherhood and mental health. And hopefully, fingers crossed, if Zoom is behaving, you'll be able to hear excerpts from a piece that we made, which was accessible in barbershops, and it was a piece where you could put headphones on and view portraits of participants of the project. And these participants had sat down and spoken to us about their experience of mental health and fatherhood. So the idea was we put this in barbershops while people wait for a haircut. They might start a conversation, or at least hear something that maybe they think, oh yeah, I can relate to that, but I wouldn't normally talk about this, or oh yeah, that's not something I experienced, but I'll bear that in mind next time I speak to someone who might. So hopefully.
The relationship that Jane and I had before Liam was born was very much me relying on her to give me quite a lot of support. And it took me a while to realize how difficult that was for her once she'd had a child, and how thankless that was. And so the relationship needed a huge amount of recalibrating, and it took about 3 years to recalibrate the relationship.
There's no family if the relationship between the two parents falls apart because they haven't had their own time to look after each other, you know. So actually, I would say a piece of advice about parenthood is it doesn't have to be all about the kids. Happy people make happy parents. Do you know what I mean? So, you know,
at the beginning you don't know them or anything, but you will die for that. You know, so it's quite. So that's kind of strange, but a lovely feeling. As you get older, when you're, I think a lot of dads will be able to tell you that, when your children are younger, You know, you're everything to that child. You know, they look up to you. You're the whole world. You satisfy all of their needs, their wants, their desires, and they look to you.
So hopefully you could hear that. I really hope Zoom behaves. And I'll now mute myself and pass you over to Callie to talk more specifically about our work around fatherhood.
Thank you, Hugh. So my name is Callie Hayes, and I'm an artist and writer. I'm also a perinatal mental health nurse. When we played that video just now, I could hear sneezing. I don't know if anybody else could. I don't think that was part of our video, but nevertheless. So I wanted to talk about the lessons learned from using art to start conversations about men's mental health. So we're really focusing on that very early work, before people perhaps reach a mental health crisis, so that there is a space where men can particularly start to recognise if they're beginning to struggle.
Oh, Callie, you've just gone on to mute.
Yes, somebody muted me. It said the host muted me, so I'm back. So shall I start again? I don't know how much was missed.
I think it was just literally sort of 5 or 10 seconds, so I wouldn't worry.
Okay, that's fine. I'll carry on. So what we found about using art is what was really important was to go to spaces where men go already, and we found that art was a useful tool to start conversations about men's mental health in barbershops, construction sites, boxing clubs, sports centres, and that men were more willing to engage in our projects if there was a project with a purpose. So, they were more interested in producing something that is tangible and useful for others, and that altruism is a motivator to engage. But what many participants found was an unexpected benefit of actually they were able to process the experience they were sharing a little bit more. And they found that actually the role of helping others had that unexpected benefit of beginning to help themselves. We also found that working with the narratives and relatable voices had actually enables an audience to engage with this conversation around men's mental health, and particularly when we had this is pre-COVID, when we had the installation in barbershops, people found that the portraits in the installation again normalised that actually poor mental health can affect anybody. So that was quite a leveller, really. So Hugh, can you go on to the next slide? So in late 2019 and 2020, we toured a show called Cracking, which told a dad's story of living with perinatal mental illness. And this was inspired by interviews with heterosexual couples who had recovered from perinatal illness. And we toured that in community spaces and theatre venues. It was a part performance, part conversation. And so we are in our post-show talks, we were joined by third sector organisations like Bluebell, Dads in Mind, DadPad and Cocoon Family Support. And we were all set to tour this more widely when COVID struck. And so what we found was that actually the story of Cracking became a lot more flexible in terms of what we could do with that in a digital space. So we adapted the live performance to an audio drama. And we created a series of podcasts with Dad Matters UK, Dads in Mind and Acacia Family Support in conversation with those organisations, responding to the themes that the play was raising and then also talking about the wider work that they do with dads. And before COVID hit, we were commissioned by the Path Project to adapt scenes of the live performance to be filmed in virtual reality to develop a training tool that then would enable healthcare practitioners to reflect on dads and partners' experience in this perinatal period. And we've just managed to film that, which was seriously delayed by lockdown, but that now is being piloted and shared across Path partners. And I think what we also would like to do is, in the future, is to film a live performance of our theatre show, to create a series of video podcasts where we can capture that part performance, part conversation, so that we can keep this conversation going more widely. And also during that sort of online phase, we again adapted the show to become a 3-hour online training course for healthcare practitioners to be able to reflect on how they could make their services more dad and partner inclusive. So if we can go on to the next slide. So what did we learn from talking with men in those theatre and community spaces when we were having these post-show talks and these conversations? And what we found men were telling us was the challenge for men to name their feelings. So they often felt that there was a lack of emotional literacy for men. It's not that men don't feel these things, there's a difficulty in being able to articulate and name that. And that their emotional expression is not often talk-based, and anger is a default emotion that can communicate quite a lot of distress, but often gets misinterpreted as men behaving badly. And yet when we explored that more, some of those sort of men behaving badly behaviours could actually be perinatal red flags for men in that perinatal period, because of their inability to be able to, well, firstly coping with what's going on, but also to be able to articulate their own experience. They also told us that they wouldn't talk to friends about any of this stuff. So there's a real case of I've just keeping my head down and I'm keeping going. And that if a healthcare practitioner did sort of ask them how they were, they probably wouldn't tell them either. So then they also told us that there's often guilt if they're struggling with their mental health in this early parenthood journey. And some of that seems to be about men being unprepared antenatally for fatherhood and the baby coming. And when we were doing our post-show talks in Exeter around the community centres, one of our participants on our post-show talk was a barber who worked and lived locally, and he had his own experience of postnatal anxiety that was triggered from supporting his partner with postnatal depression. And he was saying, you know, I never knew that it was a thing. I never knew that men could become unwell in this period. So to actually then have those feelings, there is a huge amount of guilt about, well, what do I do with that and how can I articulate that? Also, men were saying they're not really aware of what's happening in their bodies in readiness to become fathers, and not realising how important they are in this journey, you know, from the start of conception and beyond. And they also told us that they delay seeking help, partly because of this need to keep going and lots of people relying on them, but also if you're supporting a partner who's very seriously mentally ill in that perinatal period, that it's only when they start to get better that men can step back and start to engage with their own feelings. And that's often when services have moved on. So often when perinatal services are pulled out, certainly midwifery. So then men are left wondering, you know, where do I go with how I'm feeling? And then finally, I think men were telling us about the need for society to change, to acknowledge the couple's journey into parenthood. And I think men were saying, you know, that they felt excluded antenatally, and so the poster that we created with DadPad, which is an interactive version of our fatherhood installation, would be one way of actually men being able to engage with other men's stories about becoming fathers and what that was like, and that could be quite a quick win, putting the poster into antenatal clinics or spaces where men are going, where there's this discreet opportunity to download a link to the installation and just engage with some stories of men who've already done this and they're a bit further on. Men also talked to us about if they were fortunate enough to have a flexibility around their working life, and they could co-parent, that there was often a lot of isolation and alienation in local mother and baby groups or toddler groups. And so actually the opportunities for men to be able to have their emotions in this early parenthood period be normalised and validated were actually less because they were in a female-centric space. And again, it was quite difficult to know how to share their feelings. And so finally, I just wanted to say that this was work that we were doing sort of pre-COVID, really, and so we haven't had the opportunity to get back into the space with groups in the community. And I do acknowledge that things are beginning to change in terms of recognising the importance of dad's needs and partner's needs in the perinatal journey. But it still remains a postcode lottery, I think, across the country. And what the aims that we have for our work is that we want to continue to go to spaces where men go, having these conversations, raising awareness of the importance of dad antenatally. But actually being a parent is really hard. Postnatal depression and antenatal depression can affect men too, but you can get help and you can always recover. So all of the work that I've spoken about is available on our website, and please do get in touch if you want to talk to us and find out more. I realise I've sort of rushed through that, but thank you very much for listening.
Thank you so much, both of you. Again, what a fascinating project, and I've been tabbing my thoughts down as I've gone on. As you've been speaking, you can see in the chat. So we are at the end of time for this panel, but we will go on for another 5 minutes, if that's okay, to take any questions. So first of all, thank you for everybody who's commented on the chat. But if you want to ask a question, do please do the Zoom raising of a hand or unmute yourself and ask questions in the next 5 minutes or so. Just to kick us off, I think from the chat, there's lots of praise and sort of aligning and people sort of recognizing findings from their research coming through. I just wanted to ask Jane, what triggered the idea of a book? So was it a love of writing, and did that just sort of feel like the right medium with which to share the stories? So what sort of what brought you to thinking about, okay, this can really become a book? And a similar question perhaps for Callie and Hugh. It's something I put in chat because you guys seem to be sort of blending these different kinds of interfaces, some of which are offline, some online. So barbershop meets something else that's technological or digitally mediated, or theater meets film, and so on. So how do you make these decisions about sort of, right, okay, with this particular problem, this particular group of people we're trying to speak to or communicate to, this is the medium, or that is the mode, that might be, right? So how do you arrive at those decisions? Sort of similar-ish questions for you guys. And Leah, I have had a slightly more complex question to you, which is in chat, about what nuances you saw in that notion of sort of horizontal and compassionate care, and if there were any complexities within that. It's on the chat. But others, please ask questions. And over to you, Jane, if you wanted to start off with a response.
Hi, yes, Ranjana, thanks for that question. I think why a book? I think mainly because I knew that talking about my own children, about my mental health, I knew it wasn't going to be a one-off conversation and then that was it, that was done. I knew it needed to be something that was done over time, that was repeated. I didn't want it to be a big deal of, right, okay, we need to sit down and all talk about mummy's mental health. So I think that's why I just wanted it to be, I've got a copy here, because I was reading it the other night with my children. So just that kind of, that repetition and normalizing as well. So, this sits on the bookshelf with all their other bedtime stories. I've read it quite a few times with my children, but the other night one of them wanted to read it again, and she was saying, and she actually said to me, I've forgotten what a poorly mind is and how it feels. So I think it just helps it not be that one-time conversation, but just opens that ongoing friendly dialogue.
Thank you so much. Yeah, and I love the cover. It's a really nice set of colors, and yellow is a really nice color actually for this. Thank you so much, Jane. Okay, over to you, Leah.
Yeah, so I mean, I suppose what's important to think about is not that there was no conflict, but that the admins felt it was really important to kind of step in and manage that and minimize it. So there were all the kind of usual conflicts that you'd see in, you know, most other, I don't know how much you hang out in online mothers groups, but, you know, lots of conflicts around things like breastfeeding and sleep issues and, you know, and lots of other things. But the admins really felt it was really important to kind of step in and manage those and kind of help women work out how to kind of express their kind of views. So I mean, sometimes, for example, in a Brazilian mothers group, they just like expelled a whole bunch of women for being mean about someone who couldn't breastfeed, you know. And she said, you know, it's okay to say, well, I think breastfeeding is kind of good, but it's not okay to say, you know, you're a terrible mother if you don't breastfeed, you know. And that's where we kind of draw the line. But I think what I was kind of really getting at was that what was helping them to do that was this kind of dual lens. So they knew that whatever the majority kind of practices were in, say, Sydney or Melbourne in Australia might not be the same as the majority practices in Brazil or Singapore or Ireland, for example. And so just having that kind of lens made it kind of something that was really important to kind of manage. And it's just that there was a real sense that they needed to have that kind of solidarity amongst mothers in that particular kind of space. The other thing I suppose that I would say is that actually some of the conflicts came from, say, newer migrants and migrants who'd been around longer. So, for example, around kind of, say, stuff around education, for example, in one of the Indian mothers groups, you know, new migrants would often come in and say, I need to know where the best school is. Which is the best school? Just tell me where the best school is. And people who'd been around a bit longer just said, oh, well, it doesn't really work that way in Sydney or Melbourne. You know, most kids at the primary level go to their local school and there's not a massive difference in quality. So you just find where you want to live and then, you know, but then people come up, it's like, yes, but I want to know where the best is. And so it's this kind of, these different kind of, you know, anxieties about what you need to do to be a good parent and how those might also kind of change over time. So that's one of the other things that kind of really came out of my research is that, you know, it's not a static thing. You're not just a migrant or a mother, you know, there's a period of being kind of maybe new or whatever, but you know, you kind of change the way you feel about things as things move on. So it's a dynamic process. Yeah. So there was definitely a lot of kind of nuance, and I wouldn't want to kind of give this idealized view that there was no conflict at all, just that it was just a very conscious practice on the admin's part to kind of manage that and minimize that.
Perfect, thank you. And I think that notion of the generational differences and sort of the how long you'd been there and sort of your own story of migration being so diverse and different. Yeah, that's really key to take away from this, I think. Okay, and thank you. And over to you, Kelly and Hugh.
Yeah, I'm happy to answer this if you're, or I can say a few things. So just in terms of how we decide what, just double check I've got the question right, how we decide what kind of medium to use for different communities. There's never a sort of hard and fast way we decide it, but it usually just emerges from something that they'll say. So an example is that when we sort of got into a conversation with a veterans group who wanted to create some sort of resource for veterans, we sort of said, well, where do veterans go? And there wasn't really a clear answer. Would veterans want to do something online? Because that's usually the path of least resistance, especially with all this COVID stuff now. But this was predating that, was to do something online. They said not really, because there's that fear of someone might know, someone might find out, someone might see on my history that I've been going on sites about mental health. So we thought, okay, it needs to be something really discreet and offline. So then it just naturally, the last thing left really was a small pocket-sized book that you could fit in your back pocket and take away from a coffee morning or a barbershop or wherever it's distributed. And then with the construction industry project, it was originally we wanted to build a big touring shed that would go around different construction sites that had tea in it, and you could go in and get a cup of tea and there'd be speakers in there, but that was completely unfeasible. So but we decided it should be an audio thing, because actually giving out books on a building site is not practical, just in terms of like mess, dirt. They'll become very dog-eared. so that's why we did like this laminated, weatherproof, sort of bulletproof poster with a QR code on it.
And then I think I was going to say with the installations that that we later made into interactive posters is, I think, what that they provided a tool. Men were more interested in getting involved in that because they were interested in the sort of the science and the process of the wet plate photography that we used working with Stephen Rafferty and in actually producing the image that went alongside the installation. So again, it was that idea of I'm more interested if things are there's a tangible thing at the end of it and it's actually going to be quite useful. And I think in terms of theatre, it's sort of going back to storytelling, that actually this is whatever culture we've all had a sort of cultural background of storytelling, of how we make sense of the things that we've been through. And so when we took that to community spaces, we were trying to engage with people who weren't the traditional theatre goers, and actually we were putting on this performance without all of the theatrical devices of stage and lighting and set and everything like that. But actually those audiences were still transported into the space of that couple's story through the power of storytelling. And I think by using personal testimony in story, so although the play is a fictionalized account, there's quite a lot of verbatim in there. But again, that was engaging for people, that this is really interesting. This is real stories and real stories of recovery.
Thank you so much. And that's just the thing, right? So that there isn't a hard and fast rule there. And it's about that it's fundamentally multimodal and multimedia. And what a fantastic panel this has been, because each of the papers talked about these completely different modes of engagement with people, but coming together on these common themes. And that's exactly what we had in mind for it. So we have our launch event at 11:10, where Paul and I will talk about everything we've produced over this last year with the Institute of Health Visiting and the NCT. And we have speakers from the Institute of Health Visiting and the NCT and the University of Surrey talking about all of that. And we'll circulate a list of everything. So all our outputs from this project to you at the end of that panel. So please come back at 11:10. So we are running a little bit behind now, but we'll try to make up the time. Please join us at 11:10. But now you've got 3 minutes, I think, for a quick stretch your arms / make tea break. So speak to you soon in 3 minutes.
Okay, hi again, everyone. Welcome back. Hope you're able to have a very brief break. We thought maybe we'd sort of include the break in spite of running on slightly late. We hope we'll be able to sort of make up a little bit of that time in the next session, perhaps. So, as you know, the thing that sort of, I guess this event sort of centers on, if you like, is a project that Ranjana and I have been involved in with the NCT and the IHV, Institute of Health Visiting, trying to bring some of our research findings on new parents and mental health and well-being into practice to try and sort of support new parents in various ways. And this session really is going to be us discussing a little bit more about that. It will start with a paper from myself and Ranjana, where we'll just sort of give a little bit of an overview of the project, as well as sort of providing a few reflections. And then we are delighted that we've got Hilda Beauchamp from the Institute of Health Visiting and Catherine Kelly from NCT, who are going to both sort of talk about the aspects of the project that involved them. And then Tamsin Woodward-Smith is going to join us. Tamsin is the manager of the ESRC and Impact Acceleration Account Fund. And that was the fund that supported and sort of basically funded this project. So she's going to give some brief reflections too. So without further ado, I'm going to share my screen. Hopefully this will work. And we will get crack on with our first piece. Okay. So yeah, as noted, the Surrey Perinatal Project then was born out of a number of sort of research projects that involved Ranjana and or myself or us together, and was really all about trying to transform the research findings and sort of conclusions and recommendations from those projects into sort of real things that could help parents. So, and specifically, some things that perhaps you could say were sort of direct interventions to try and support parents directly, and others that involved sort of engagement with practitioners of various different kinds in order to do so, in order to kind of have that kind of impact. So I'm just going to say a little bit about the background. So both of us have been involved in researching parents and new parents in relation to perinatal mental health for a few years now, and there's a few sort of examples of books. So Ranjana's book, Early Motherhood and Digital Societies, you can see there, and a book by both of us on new fathers, mental health and digital communication, various other papers and so on, and reports that we've been involved in as well. There are three particular projects that have a sort of more direct sort of connection to this current sort of work that we've been doing with IHV and NCT. The first is a project by Ranjana on mental health taboos and British South Asian new mothers. That project particularly sort of highlighted the role really sort of gendered ideologies to mother perfectly and intensively, and the kind of pressures that placed upon people. Particular pressures as well, kind of not to complain, not to sort of seek support sometimes for mental health difficulties, on the basis of sort of a discourse that baby is a blessing, which is particularly sort of strong within sort of some communities that were involved in the research. Also kind of other feelings about like feeling monitored and not feeling able to speak out or seek support for that reason, and cultural roadblocks of various kinds in sort of feeling understood in the difficulties and struggles that one might be going through. The second project, which was a joint project between both of us, was on new fathers, mental health and digital technologies. This project particularly sort of highlighted the way that fathers sometimes can feel somewhat marginal or peripheral within the perinatal process, and the ways that can sort of have a knock-on effect in terms of whether they feel that it's legitimate or reasonable for them to sort of suffer from mental health difficulties and seek support for them. Connected to that, we also sort of found quite strongly that fathers were feeling under pressure to be the supporter, the kind of supportive rock, and that needing support themselves was kind of problematic in their eyes in that regard, and then was a further sort of difficulty for them seeking help. and in general, that you know, sometimes digital technologies and other sort of resources helped them, but various of the fathers struggled to seek support and express their needs. The third project was focused upon having a baby during the pandemic and the specific kind of challenges that led to for new parents, and again with a sort of connection to new technologies. That project highlighted heightened isolation, various sort of needs that people had that perhaps normally would be sort of met but were not being met as a result of the pandemic, which we've sort of mentioned once or twice already today. Closed down services, services sort of moving to sort of a digital only kind of platform, a lack of privacy within the home sometimes because everybody's at home during particular lockdown periods, exclusion of fathers and co-parents from sort of key moments in the perinatal process, and the move to digital, and the way that didn't always sort of provide all of the things that people were getting from sort of more face-to-face forms of support. Okay, over to Ranjana.
Okay, so as Paul said at the outset, this entire partnership with funding from the ESRC was about taking research findings outside of books and journal papers alone and taking them to practice in one way or another. So we then took these highlights, these research highlights that Paul shared in the last slide, into our work with IHV and NCT, and we produced a set of resources, different kinds of things, not just one kind of thing, that our colleagues from the IHV and NCT will get into in more detail when they speak, but just to provide you a quick summary and a quick overview of what we did. So on the right there, you can see a glimpse of our website. We are very pleased and proud in terms of our website. It's very comprehensive. It lists all our publications, all our outputs. So please feel free to look at it, surreyperinatal.net. But basically, our work went in three directions in terms of taking research into practice. First, with the Institute of Health Visiting, we produced things called factographics. So very clickable, living, in a sense, digital resources, which contained numerous links and stories of lived experience and resources for parents and professionals produced in conjunction, in association with parents and professionals. We also produced evidence reviews for the NCT in terms of producing sort of reviews and summaries of the state of the art in key topics around perinatal mental health to feed into and inform their parent-facing content for the public. And we have been developing various kinds of practitioner training and engagement, including teaching on specific modules to do with perinatal mental health. So factographics first, as you can see there, the very colorful logo on the right saying factographics, and importantly for parents and professionals, by parents and professionals, work we did with the Institute of Health Visiting, which was absolutely fascinating. These were interactive resources we designed to support good parental mental health and well-being, taking those findings that Paul spoke about from those research projects, and thus embedded in specific evidence in specific research projects, developed collaboratively via parents and experts forums. So we repeatedly met with parents and professionals, and we carried those findings into imagery, videos, personal stories for use directly by parents or perhaps by professionals and practitioners in their interactions with parents, rooted in those specific research projects. And the three factographics you see there on the screen, I mean, I don't have the time to click these right now, but you see the factographics up there. And I just wanted to highlight one particular thing. So as you see, the COVID project led to the new parent during the pandemic factographic. The work with South Asian migrant mothers led to the factographic called A Baby is a Blessing, So Why Do I Feel This Way? And the project on new fathers, perinatal mental health, led to the last one called New Dad, You're Not Alone. But the one thing I really wanted to highlight now is that everything you see on there, every little image that's there, represents a specific research finding from a specific research project. So these aren't coincidental, and these weren't just picked out randomly. These were sort of produced in association with parents and us, of course, and they represent specific findings. And the one that I will highlight just by way of an example is in the second factographic that you see there, A Baby is a Blessing, So Why Do I Feel This Way? On the left, you see a mum with a little baby alone in the middle of a crowd and people telling her, well, a baby is a blessing. Why do you feel this way? That came up from loads and loads of interviews with mothers. So that's just one example, but you also see there are stories there are clicky links and all sorts of things. The next set of things we produced were these evidence reviews. You see screen grabs up there on the bottom right of what these look like, but basically we reviewed the literature and the scholarship as it stands on 4 quite distinct topics for the NCT, with a view to these reviews then informing the NCT's producing or reviewing content on their website that parents and members of the public can freely use and access. And these topics were the perinatal mental health of mothers from migrant communities, paternal perinatal depression and anxiety, fathers' experiences of birth trauma, and fathers' experiences of perinatal loss. So you see, these are really specific, and in many cases, and perhaps I'd say even most of these cases, literature on these were often limited. It was a very interesting task to really get into the literature in depth and produce these evidence reviews, which we've made available, by the way. They are linked, hyperlinked on our website, surreyperinatal.net. So you'll be able to access these evidence reviews. And we, Paul and I, would also circulate a 1-page summary complete with all the hyperlinks of everything we've produced at the end of this panel. So keep an eye out on the chat for that. And the last thing to highlight there is practitioner training and knowledge exchange and engagement, which we've been doing throughout the course of the project. And the 2 images on the top left there are very good, because one shows us doing something offline in person, and one shows us doing something online. And we've done both. As the pandemic has progressed, what we've been able to do has sort of had to change, but largely we've been developing workshops and sessions for students on different kinds of modules at various universities, engaging with health visitors in different ways, organizing sort of large events. So we've done specifically for the NCT practitioner-oriented infographic workshop and live webinar for NCT practitioners. We've done workshops for the NCT and for the University of Surrey for people studying nursing or community public health. We've engaged with health visitors at several IHV forums and events, and we've organized sort of events kind of geared towards members of the public who are not professionals or practitioners. For instance, our event last autumn had close to 300 attendees. So that's something we have been doing throughout. So over to you, Paul.
Okay, so we just thought we'd maybe just mention briefly perhaps some themes or sort of principles that underlay the project and perhaps emerge during it as well, and perhaps these also connect to some things possibly that we'd suggest be sort of taken forward further. So destigmatizing, I think, was a big part of what we were trying to do, trying to make perinatal mental well-being difficulties normal, possibly like slightly demedicalizing a little bit, slightly taking the big box around sort of mental health struggles and trying to see them as something perhaps to be expected in certain circumstances, something normal in certain circumstances. I think we wanted to specifically challenge what we regarded as sort of potentially harmful stereotypes, discourses of one kind or another. One would be the kind of baby as a blessing, so therefore, you know, one should be sort of delighted and sort of feeling fulfilled all the time. Another would be the kind of father as rock of support. Both of those we sort of found in the different projects were kind of leading to sort of difficulties to people in their ability to sort of recognize and sort of cope with mental health difficulties. Clearly, a big part of it was trying to sort of make sure new parents as much as possible are sort of informed about perinatal mental health challenges so that they can recognize difficulties and seek support more easily, but also like a particular emphasis on legitimizing, so enabling people to see struggles as something that's legitimate, something that's valid, because I think findings, particularly from the Fathers Project, but also some of the other projects too, kind of really revealed that was a difficulty, that even once people had sort of recognized that they were struggling, that they were having difficulties, that then often led to sort of spirals of guilt because of feelings that it wasn't okay for them to be struggling at that particular time. It wasn't valid, it wasn't legitimate. So I think that's something that we sort of tried to address through much of what we've done. including fathers, I think, and by extension, all co-parents as full participants in the perinatal process as well, and not just as supporters. I think that was a key thing too in a lot of the talks that we did and various other things. In this particular project, it was specifically focused on fathers because that connected with our research project, which was on fathers, including various sort of gender-specific things that they were facing. But we'd want that, of course, sort of extended to sort of all co-parents going forward, and in terms of how they are sort of understood and how they're sort of positioned, if you like, by various parts of the process. Addressing particular challenges that people have faced during the pandemic obviously was sort of key to one of the research projects and sort of very much fed into things. And also kind of supporting the needs of sometimes neglected or marginalized groups of new parents. Now in this project, because of our research, that connected to fathers and it connected to sort of migrant mothers particularly probably, but there are also of course various other groups that have been sort of discussed today that can be sort of extended to, we hope. And enabling new parents to connect with one another as well, I think is sort of really key, and with professional support. So finally, we just want to sort of thank you, lots of people, to the really sort of fantastic colleagues that we've worked with at both IHV and NCT. We're so grateful for all the efforts that you've put in, and your openness to ideas, the way that you've sort of worked with us and so on. Couldn't be more grateful. To all the practitioners and parents as well who we've engaged with at the various events and other things that we've sort of done throughout the project, to the ESRC for funding the project, and to the ESRC Impact Acceleration Account Fund managers at Surrey who have been enormously supportive of us, and Tamsin, who's one of those, is going to sort of speak to us in a little while. And of course, we'd really like to thank as well all of the speakers and participants for today's event. Okay, and as chair as well as participant for this session, after ourselves having sort of talked about the project, I'd now really like to invite Hilda Beauchamp from the Institute of Health visiting to talk to us about the bits of the project that we were involved in with the IHV.
Yes, thank you, Paul and Ranjana. I'm delighted to be here with you this morning. It's been a fantastic morning so far. So I'm just going to take you into a little bit of a deeper dive about the Factographics project that we were collaborating on. Hopefully you can see my screen there. So those of you who are not familiar with the Institute, we're a charitable and academic organisation supporting the development of universally high quality health visiting practice and leadership to support and improve public health outcomes for children, families and communities to reduce health inequalities. And my contact details are there on the front. How often do you get asked to contribute to a survey, or you fill out a research questionnaire, you dutifully send it off and then you hear nothing further? Too often, I suspect. And at the Institute, as well as you know, Paul and Ranjana, we're very conscious of parents and professional participants in research who remain unaware of how their responses have maybe affected that change. So we were really delighted to have the opportunity to participate in a project that enabled professionals, parents and researchers to extend that collaboration beyond the original research and for it to be translated into something meaningful and tangible and to benefit others. The term factographics was actually coined by Melita Walker, who you'll be hearing from later. She is the head of the mental health department at the Institute, and she envisioned a product that could address unique and unmet perinatal and mental health needs, something that could be co-produced, and it could be a national template with opportunity for local implementation. Because we all know, everyone here knows, that perinatal mental health problems in the time around having the baby are common, and that there can be short and long-term impacts on the whole family if they're left untreated. But we also know that early identification and the right support increases the opportunity for good outcomes. So the 3 new interactive factographic resources to support perinatal mental health needs were addressing groups or areas where we knew there were unique unmet needs. And as Ranjana's already said, these were picking up on these 3 topics: new fathers, the second one around a baby is a blessing, picking up on the mental health taboos and the British South Asian new mums. And then I do have a clicky one, Ranjana, so I can click on this. I just thought I would hover on this slide about becoming a new parent during the pandemic and picking up on the themes of the heightened isolation and the reduced services. So each of the resources is produced and it can be viewed as a web version like this, or as a mobile version, or a downloadable PDF, which gives practitioners or parents an opportunity to add local information and be able to use it as, you know, posters or in clinics. They are clicky, so this brings up the key messages from each of the research. We have a section on each of the resources for additional signposting to reliable sources of support. And then there are lived experience films and films from health professionals in each of them too. These were, you know, really valuable aspects of the resources. I'm going to just share a little bit of the films now. The sound might be slightly quiet, so you might need to pop it up on your own screen.
My health visitor was great. She would phone me every week to check on my mental state. I would say that the lack of face-to-face support from a GP or from a health visitor was the hardest thing. We didn't even get video chat, it was all done over the phone, and I just needed that face-to-face contact with somebody. Being a new mum, I had no idea how my little girl was growing, how she was developing, whether she was healthy weight, and I had nobody to take her to show her to ease those fears, and that anxiety just sort of made everything 10 times worse.
We recognise that the pandemic has had a massive impact on parental mental health. It's been a real challenge for many, with the isolation, juggling homeschooling and working from home, and not being able to see friends and family. We know that our service has changed and that you've been unable to access our clinics and meet other mums. This has caused many of you lots of anxiety. Across the country, we have seen an increase in mental health issues, and parents have reported struggling, depression and anxiety with the isolation and lack of practical and emotional support.
We're here for you. We want to support you, and we're here to answer any question that you may have. Please don't struggle in silence.
So it's been a really collaborative process. We've used the parent professional workshops to gather information, establish parameters and principles, and then subsequently feedback on the prototypes. There's been lots of discussion between everyone to fine-tune the resources and then commission these films from parents with lived experience and the professionals to embed within the resources. But it's been a lot of fun too. We've had feedback about the colours that we've used, where the health visitor should sit. We've tried to avoid perpetuating the notion that health visitors just go around for a cup of tea and a bit of a nosy around the house. And you can see we took on board the feedback about the guy's beard, but I'll leave you to decide about the size of his feet. We've discussed how to ensure that parents can access support, what were the key things we needed to include. And there was also that opportunity for reflection about how the resources resonated with the experiences of the group members themselves, some of them who had become parents themselves during the pandemic. And we've gathered thoughts on grammar and punctuation, on inclusivity, on the generalizability of the resources. And one of my particular favourites was from a mum who thought that our use that the exclamation marks made the resources a bit shouty and we needed to be a bit more softy. So it's been a really iterative process. But hopefully you can see from some of the comments here in our final feedback just how valuable the collaboration was felt to be. I think we're all incredibly proud of where we've landed. And we wanted to use this as a test bed and pilot. We know that involving parents, professionals and academics is what's needed for something to be truly useful. So our next steps really will be to do a robust evaluation of how the resources are being used and in practice, both by professionals and parents. We've just published a survey link that I'm sure will be available on the Surrey site and also on the Institute of Health Visiting website alongside the factographics. So do give us feedback if you are one of those who's using these resources in practice. And we'd love to find out about other unique needs for new parents and special interests out there. So, if you're sitting on a pot of money or you've got access to funds and you think this might be something that you are interested in, then please do get in touch. And I'd also just like to add my thanks to all those who were involved in this particular project. Some of these names will be familiar, you've heard from them this morning already. And I'd like just to particularly thank Lisa and Jay from the Institute who did all our design work and graphics and also helped put this presentation together for me this morning. Thank you.
Thanks so much, Hilda. That was great. And we too are very proud of all that we achieved there too. Now really happy to introduce Catherine Kelly from NCT, who we worked with particularly in relation to a number of events and infographic practitioners that we created and various other things. Over to you, Catherine.
Thanks very much, Paul. It's lovely to be here. And let me just start off with a bit of sharing. So that's me. And I'm going to talk about some of the work that I've particularly been involved with. So Paul's already mentioned that he and Ranjana have produced some evidence reviews, which are going to inform our website. And I've also located them with some other resources for practitioners. The work that they're doing is feeding into the training of future practitioners. I'm going to talk mostly today about the work that we've done on continuous professional development for our existing practitioner body, and we've focused very much there on the fathers. So I organise the CPD for practitioners, and we have around 750 practitioners, about 60% of them working on antenatal courses with parents. So all of our practitioners are trained in adult learning, focusing on the perinatal period. So some of the things they are picking up there and their learning is that the value of small groups to provide safe spaces for parents to discuss issues, and also helping to build a really supportive social network so that they can support each other after the end of the course. We also focus a lot in the training on inclusion. So that's mostly life partners attending the course. So that's fathers and co-parents, but also sometimes birth parents such as grandmothers, friends, and so on. So let me go back to my slide and just show you how the antenatal course is underpinned by some key principles and some themes. And you can see that we've got down here, number 4 is taking care of physical and mental health. Now that encompasses the whole perinatal period, and it also includes mothers, fathers, and other kinds of parents. When we're talking about mental health, we're talking about a normal range of health, the massive kinds of variation. We're also talking about how parents can support their own mental health, and also recognizing the signs when it starts to become a cause for concern and where they can get support for that. So you should be able to see that the work we're already doing really aligns with Surrey's key messages of inclusion, providing information for parents and helping them feel supported. And I'm talking specifically now about fathers in this. The challenges that practitioners face, of course, are that the parents are then going to leave us and go into the maternity system, which we can't really do a lot about. We also have to try and raise awareness of mental health issues without causing anxiety for parents about those. And we have real-time constraints. So in preparation for this, I just looked at, on the last course that I taught, because I'm a practitioner too, how long I was able to spend on perinatal mental health issues. And I found that I spent about 10 minutes giving information of everything from the normal to the complex. Then we had about 15 minutes where the parents were able to talk with each other about how they were going to protect their own mental health. And then we had about 10 minutes mopping up, addressing questions and signposting them to useful sources of support. So it's quite a tight amount of time. But of course, it's not just the time I spend focusing on mental health, it's also about how we are inclusive of fathers right from the outset. So welcoming them into the session, asking them how they're feeling about being pregnant, making them feel included right from the outset, really focusing on making sure that we consider that their experience is completely valid. Including them in discussions around their well-being, physical and mental, and really bringing in some analogies, that's what I do anyway, for the massive life transition that it is to become a parent, to become a father. But you can see that with all these time constraints, having the bullet points from Surrey is really very useful for us. So what we had, Paul and Ranjana came along and they did a webinar for us around perinatal mental health in fathers, and the practitioners, after they'd presented their research, the practitioners were able to ask them lots of questions, just as we're doing here today. And they had some quite challenging questions because it's all for practitioners about the how do we do this? You know, it's great to have the information about how we're actually going to convey it to parents. But it was really good to reflect on that 10% figure of 10% of fathers experiencing perinatal mental health difficulties. Of course, that's a diagnosed figure. The real figure will be much higher. We talked about the vocabulary, the real importance of including fathers and dads, even though we're also adding more inclusive vocabulary to talk about parents generally. We talked about ways of overcoming the reluctance that fathers often exhibit to engage with the idea that their mental health might be an issue, and ways in which we could push them to engage with it by saying, look, becoming a parent is tough, so what are you going to do to help yourself get through this period? So let me go back to the slides again. And practitioners really valued that webinar, found it very useful to have the basic information reiterated for them, to have the explanation of how fathers, even those who are normally quite open with discussing their feelings, they can find it particularly hard in the perinatal period. We had some really good discussion about normalising the spectrum of well-being for both mothers and fathers. And we were talking a lot about how we can explicitly address those really unhelpful and undermining messages that fathers should be a rock and be there and their feelings don't matter. So it was really helpful for us to be reminded that in our courses, we can really help give the fathers permission to need and to ask for help. So what I wanted to do next was share with you the resources that Surrey have helped make for us. So we put together a, go back up to the top, an information sheet for practitioners to back up the webinar. So we've got here an overview of the background evidence, but then also the specific research that Paul and Ranjana have done. And then we've moved on to having some case studies for practitioners to be able to refer to for their own learning, and then a nice bullet point summary there of different things that practitioners can do to support fathers. And Paul and Ranjana also produced for us an activity sheet with a couple of different activities and again some case studies to illustrate how we can work with parents. So for those who are a bit less confident, how they can actually do that. What we're hoping to do to develop now is also a parent-facing infographic, because it's really useful to be able to leave parents with something that they can refer back to in the future. And we're going to have some illustrations on that and some quotes. Now, a top tip for future researchers, we weren't able to use the quotes from Paul and Ranjana's research because we didn't have permission to do that. So we're going to use some other ones, but really useful if you are doing research to get that permission in future, because it just provides that vivid immediacy for parents that they can use that. But we're going to use some other quotes for that one. So as I said, the parents found it really useful, the practitioners, sorry, found it very useful to have that research. And here's a lovely recent quote from a practitioner. She says, "I've just used some of the information and suggested activity from the Fathers in Perinatal Mental Health webinar with an antenatal group, and it started an excellent conversation about communication and showing vulnerability. I would definitely recommend it." So thanks very much, Paul and Ranjana, for all of the work you've done on this. It's been really useful. Thank you.
And thank you, Catherine, for all your work working with us and for that great talk. Thank you. And now our last speaker in the session is Tamsin Woodward-Smith, who's a colleague of ours at Surrey. And she is manager of the ESRC Impact Acceleration Account Fund, which is what sort of enabled this project to happen, really, what funded the project. And Tamsin's just going to give us a few sort of reflections and say, I think, a little bit about the fund and what it does.
Yes, absolutely. Thank you so much to Paul and Ranjana for the opportunity to speak here. My name is Tamsin Woodward-Smith, and I'm the ESRC Impact Acceleration Account Manager for the University of Surrey. I'm really pleased that Ranjana shared that a lot of the people on this webinar this morning are not academics. So for those of you who are not academics, you might be wondering, what is impact and why are universities concerned about it? So impact is the changes and benefits into the real world from research findings. And Paul and Ranjana have been giving a brilliant illustration in all the talks so far this morning of the ways in which that can happen in collaboration with practitioners. And you might also be wondering what an impact acceleration account is. So IAAs, as we call them for short, because it's a bit cumbersome to say impact acceleration account repeatedly, are grants of funding from research councils, which means that they come initially from taxpayer money to universities to be able to use to support impact generation and building skills for researchers around impact generation within universities, and to enable partnerships with external partners. Impact is a really important area of focus for universities, and funding opportunities like IAs are increasingly central to how we're able to support researchers to generate impact from their research findings. It's really important that we're not in academia just an ivory tower, but that we allow research findings to escape into the real world, as it were, and to have the opportunity to make a difference, which I think Paul and Ranjana have really brilliantly illustrated today. It's lovely to see the depth of the connection. It was I've seen small versions of the factographics and so on before, but it was really lovely to have the opportunity to kind of explore those and to really see the depth of the connection between the research findings and the outputs, which I think was really inspiring. From the IA, we're really delighted that we've been able to support Ranjana and Paul with this project, which touches on some of the really important themes that are key to ESRC as a funder, in particular around digital technologies, mental health, health inequalities and parenthood. Ranjana and Paul have done a really fantastic job of building really strong partnerships with both NTT and IHV and the other partners in this work. And that element of co-creation with the partners shows in the really impactful outputs of this activity, as we've all seen this morning. I'm really pleased to be able to be here today for this launch event, which has been really fascinating. And I want to thank Ranjana and Paul for all their hard work on this project, to congratulate them and the partners for the achievements here. We're really excited to see where this work goes from here, and we're looking forward to hearing lots more about it.
Thanks so much, Tamsin. Fantastic. And thank you for all your support and the various questions that we've asked you along the way and the various things that you've done to help. Okay. Thank you to everyone for all your talks in that session. Ranjana's just sharing now a one-page document which just really lists the various outputs that have come out of the project, and some of which are directly accessible via our website and other places. So do have a look at that in the break now, whenever you like. We've just got just under 10 minutes or so now for discussion. As before, do put things in the chat if you've got any questions that you'd like to ask, or if you want to put the virtual hand up, as it were, to ask a question. one thing I thought we might make sense for us to sort of focus on in sort of reflection might be perhaps in light of sort of what we've done in this particular project and the activities we've done, what would you see as the most important priorities in supporting parents going forward, whether that's sort of new things that are different to what we've done here, or whether it's things that sort of build on what we've done here? I don't know if I could maybe sort of ask Hilda and Catherine to sort of respond to that first, and maybe Ranjana might have thoughts too. Hilda, do you want to go first?
Yeah, so I suppose, I mean, it's interesting how beautifully dovetailed everybody's presentations have been, and the overlapping consistency in the findings and the feedback from parents. And I suppose for health visitors in particular, it's thinking about, you know, what new innovations have been tried that have been good, and how we hold on to the good bits. So for, we know for some families, you know, the digital offer has been a really positive one, but for other families it hasn't. So, you know, how do we move forward, you know, giving a you know, a robust offer to all the families. I was sort of struck, it was Pooja's comment actually, that people aren't hard to reach, they're just easy to ignore. And I suppose it's you know, it's thinking about how we make sure that things are really visible. So certainly from the factographic side of things, you know, I think it's been a great resource to develop, because, you know, practitioners and parents can share them widely with one another. It's a very easy thing for them to engage with, and you know, very easy for you know, for local information to be added onto the resources, just to increase that signposting and support.
Thank you. Catherine?
It's a really interesting question, because there's so many competing demands, but I suppose the principal thing is parents are always so surprised when they hear that they have a voice. Which is interesting, isn't it, that we have this point where adults are turning up at courses and going, oh, you mean I get to say, I get to decide. So just opening that up as a possibility for them is huge. So giving them, recognizing that yes, their point of view is valid, and then giving them the tools for how are they going to discuss with health professionals, discuss with each other. So I guess these are the sort of things we're trying to give them, isn't they? We're trying to raise the awareness and then give them the tools to actually have those conversations.
Great, thank you. Ranjana, I don't know if you had any thoughts to add?
No, but I just wanted to echo what Catherine just said, that I think that enabling part of it, because part of the, you know, in our slide deck as well, when we talked about it, I think we coming into this project with a sort of a rough-ish idea of what impact meant, and thinking, okay, these are the XYZ things we might do, to going through that whole journey, working with parents and practitioners, and actually watching things evolve in terms of seeing research findings that usually stay in papers become things that people feel like they have say in, and that they can use, and that are often like tangible things. I think that really fed into what we were trying to do in terms of sort of enabling people to feel they have a voice, enabling people to use things directly in their actual lived everyday lives. I think that, I mean, obviously that brought its challenges, but I think that was also sort of the top highlights of all of this.
Yeah, and I think I'd add to that certainly a highlight for me was I suppose the real sort of like obvious sort of keenness of so many people in different roles and with sort of different responsibilities and so on within perinatal health to sort of really engage with us and engage with our findings, to sort of share their experiences and how they connected to things or were different to things or whatever. And so I think we learned a great deal too, but that sort of willingness of the sector really to engage as we saw it, I think was really sort of striking. Another thing I thought we could perhaps discuss was I mean the obvious thing that sort of been focused upon at various points through this event is the pandemic itself and sort of reflections on that. And obviously some of our project was specifically in relation to that, some of it wasn't. But what do you feel we've sort of learned? Where are we, and what are the sort of priorities in terms of sort of supporting parents as we well, I suppose you can't really say that we're coming out of the pandemic, but as we go into a different phase of the pandemic? I don't know if anyone's got any thoughts on that.
I think I just literally replied to Annie on chat, but I think that there's a broader point here. I mean, while this project was, it was a very specific task, right? I don't know if you've communicated that clearly, but these resources were produced. The factographics, for example, were produced out of really specific for existing research projects that sort of, they were done, when we got funding to do the impact work out of this. But I think the conversation happening now is really about, okay, so these sort of work, and they were nice. What else could be done, both in terms of research, as we saw in the evidence reviews, lots of areas which are sort of really under-researched. So there's new research to be done, and we'll always say that as researchers, but there really is more research to be done, I think, but also sort of new things to be produced, new factographics and new resources. Some of the things identified in the chat, for example, some of the things that were coming up in the first and second panel today, under-researched areas, many of these, and areas where impact resources could be produced, I think. But also I just wanted to add, and this I think connects to Pooja's talk a bit and also Leah's talk earlier, but I mean, sitting in the global north, we might make a lot of assumptions about various things in terms of, resources, public health, the point at which the pandemic is, and we sort of take these things for granted, and that's vastly unequal and dissimilar across the world. So I think it's just important to be really mindful of that and bear in mind that there's so much more to be researched and so much more to be done, because people are experiencing these things so differently, even within the global north, but also outside of it.
Thank you, Ranjana. Maybe I could sort of put that question that's coming on the chat from Annie to Hilda and Catherine as well. Annie says, I'm particularly interested in how this research can be applied, extended to take into account the extra challenges, needs of new parents who have a new baby with additional physical or psychological needs. I don't know if maybe I could ask Hilda first again and then Catherine.
Yeah, Annie, thank you. I mean, interestingly, one of our lived experience films that our mum, who actually has given the film for the blessings factographic, actually touches on that because she had a baby with additional needs. But we do recognise, I mean, I think as part of the process, people were coming up with lots of ideas, and we had to remain very true, didn't we, to the kind of, what had come out in the specific research, and keep that resource and tied up with the specific findings. But in the process, we were generating lots of, other ideas of what could be produced. And I think certainly, just having a particular focus on the extra challenges and needs of parents with children with additional needs. I mean, our projects team at the Institute is doing quite a bit of work around that sort of separately, and have been mulling over some ideas for a similar sort of factographics resource that might actually meet the needs of that particular area.
Okay, thank you, Hilda. Catherine.
So in some ways, it's a bit depressing, isn't it? Because we've been working on maternal mental health for donkey's years, and we haven't fixed that yet. And now we're looking at paternal mental health. And each year there's another new complexity that we think, oh, actually, we should really deal with this. And that cake of public health funding is not getting bigger. So it's a real challenge for us to try and work within these incredible constraints with all the things we want to do. Excuse me. But what I find really heartening is the creativity and the really clever and interesting use of new technologies that's been exhibited during this conference. So all these different and interesting ways that we're able to engage with parents and help tackle some of these issues. So I'm not specifically answering your issue, Annie, but I can see that just from all the different ideas that are coming up here, there are some terrific ideas out there, and I'm really excited to look at different ways that we can put them into place in the future.
Okay, thank you very much, and thanks to everyone for speaking in the last panel. We are now going to take a 5-minute break, if that's okay, but please do join us for what should be, we hope, like a really fascinating last session with really excellent speakers. So if you could come back at 12:05, that would be fabulous. Thank you.
Hi, everybody, and welcome back to our final panel for today. And in a sense, this panel is similar to things that have gone before in the sense that we talk about perinatal mental health still, we talk about new parents and parenthood and the difficulties with supporting new parents. But in some ways, it's a bit different because the idea behind this panel was to now take a step back from the individual research projects that we've spent so much time with this morning to look at policy and practice and the institutional realm of things more broadly, to do that broad brush overview of things of really what lies ahead, what are the key challenges in the sector for the future, what are some of the key initiatives that we need to know about or speak about. And to do that, we've brought together speakers today for this final Futures Roundtable, as we call it, from leading institutions in perinatal mental health, including the Institute of Health Visiting, the Maternal Mental Health Alliance, Fathers Network Scotland, and the National Childbirth Trust. We've all heard about these institutions and the fantastic work they're doing to address key gaps and key challenges. And now we bring together speakers in this panel who are going to reflect on what lies ahead, what the key challenges are for the future in perinatal mental health. So we start today with Melita Walker, who is Pioneer Fellow of the Institute of Health Visiting and currently IHV's mental health lead. She's president-elect for the UK and Ireland Mercy Society and has worked in a variety of roles in mental health and public health. And she's going to talk to us about her visions for the future and future challenges. Over to you, Melita.
Okay. Is my screen sharing?
Yes, it is.
Okay. Whoops. There we go. Well, before I deliver my talk, I'd really like to put on record the Institute's gratitude to Ranjana and Paul for all their time and their efforts in working alongside us and for creating such an amazing opportunity for us all to come together to think together about how we can support parental well-being amidst COVID and beyond. I mean, today we've heard about facts and figures, we've talked about the increase in unmet need, and today I do feel we've really seen and heard the people behind them and the challenges that there are to family well-being. It's been absolutely fantastic to hear from diverse backgrounds and perspectives and to learn about the creative and really sort of inspirational and innovative efforts that there has been across the sector to prioritise well-being of families during what has been a really difficult time and what continues to also be a hugely challenging time. So before I go on to my talk, I'd just like to reflect really on some of the thoughts that have popped up into my head and some of the themes that have come through to me from what I've listened to so far today. I think firstly, what's come through really loud and clear is when you get people with a common interest and passion coming together, great things happen. And I think success and good outcomes depends on good relationships, good infrastructure, and good ways of working well together. And that is across all boundaries: political, geographical, organisational, professional, etc., etc. I think working in partnership with parents and families and including the voices of infants and the wider family and making sure that care is personalised to the individual and also to each individual family, that's come through for me today as critical to family well-being. And I don't think there's ever been a time really where it's been more critical to focus on family well-being. New parents and their families have had such a different introduction to becoming a family, and many have faced really significant challenges, as we've heard today. The evidence from the work that Paul and Ranjana and the other leading lights that we've heard from today, and the ones that we're going to hear from, well, we're still yet to hear from, show important implications for family well-being. Need is greater than ever, and the right care for babies and their parents in the perinatal period cannot and should not wait. But what of the challenges? How do we achieve the greatest good? the complicated way our systems are set up often mean fragmentation with COVID. And with COVID, sorry, many parents, and particularly new parents, have fallen and are falling still between the gaps. I'd like to suggest that when we're thinking of the future, to enable good parental, good family well-being, that all parts of the system that work alongside new parents and their families in the perinatal period need to be strong, and that a chain is only as strong as its weakest link. And as such, I'd like to invite you to listen to a very short presentation on the role of health visiting, focusing on health visiting in parental well-being, particularly because I want to flag what's already come up in the chat box, recognition that in England, health visiting is probably the weakest link. It's the link that's most challenged currently, and yet it's one that offers a really strong infrastructure to the rest of the system, and as such provides massive opportunities to support the well-being of families. So let's have a think about that, and let's start with what a health visitor is and what a health visitor does.
Health visitors are qualified nurses or midwives who go on to study at a specialist level in public health to become health visitors. Health visitors are uniquely placed to support new parents' well-being through their statutory universal reach. Every family has a health visitor, and they are there to support all members of the family to enjoy good health. And health is affected by a multitude of things. So health visitors may be working with new parents to support a very broad range of need. And those needs, left unsupported, as evidence is showing, can tip families into experiencing many health problems. Health visitors have a vital role in supporting the transition to parenthood, promoting good family relationships, good physical and mental health, indeed preventing mental, physical and social health problems occurring, identifying them early, offering evidence-based interventions and care coordination when more specialist services are needed. Family wellbeing is the bread and butter of health visiting. That said, health visitors can only do this if they are in sufficient numbers with the right capacity, and there is now overwhelming evidence that health visitors in England are now so stretched by the increased levels of need in their enormous caseloads that as a result, they are only seeing the tip of the iceberg. Many parents are reporting that they have not seen a health visitor for months. The root cause of this sad situation is not the failure of health visitors who have gone above and beyond to support families in the pandemic, but rather the consequence of years of cuts to the health visiting service, which without redeployment entered the pandemic in an already depleted state. Early on in the pandemic, we recognised that families, particularly new parents, would need their health visitor more than ever, so we lobbied hard to stop redeployment. And we were very relieved when England's Chief Nursing Officer, Ruth May, PHE and the LGA sent a letter to all the directors of nursing stating that health visitors provide frontline work and should not be redirected to support other services. And during the pandemic, many areas actually did not redeploy, but in some services in England, up to 63% of the health visiting team were redeployed. So we can see with redeployment rates differing substantially, families' access to health visiting services was determined by their postcode. The learning we now have and the swell of voices from parents, academic colleagues, professionals and organisations like the Maternal Mental Health Alliance, the 1001 Days Movement, Parent Infant Foundation, NCT, I hope means we can be confident going forward that for this and for any future pandemic, health visitors would remain on their own front line. We are also hopeful that the upcoming spending review will contain some significant measures to reinvest and strengthen health visiting numbers and the health visiting offer for families so we can meet the unmet needs, the increased needs we know families have been struggling with and are struggling with. The pandemic and its impact has been particularly difficult for those in cramped and inadequate accommodation, and many families have been tipped into vulnerability and poverty. For some families, home has not been a safe place, as rates of domestic abuse, serious incidents and child maltreatment have sadly all increased. Rates of mental health problems are increased and inequalities are widening. The family-centred holistic role of the health visitor cuts across all of these and can make a difference in all of these areas and many, many more. We know that pregnancy and birth can be a trigger for poor health amongst those that previously didn't suffer from any mental or physical health problems. And this time is also a major factor in the escalation of existing ones. The first 2 years of a child's life are really important for their development, and the continuity of personalised care that health visitors can offer at this time can make a huge difference to short and long-term outcomes. There's been such a lot of learning from and throughout this pandemic, and I must pay tribute to all those parents whose journey into becoming a family has been so different. You have done an amazing job, and there is no greater job in the world than being a parent. I want to also thank all the health visitors and our colleagues who work alongside us, who have worked tirelessly and are still working really hard in some very challenging circumstances to find ways to stay alongside families to make sure that they receive the care and the support that they need. We've heard of some fantastic examples of health visitors turning to new ways of working, and to get all of this up and running in the speed that they have is commendable. And on that note, in relation to the digital offer as a temporary service workaround during lockdown, virtual contacts have definitely been better than nothing. And they will have a place in meeting the need of some families some of the time. However, we are concerned by emerging reports that they may become business as usual for delivery of health visiting services. We would not normally accommodate such a significant change to a service delivery model without robust evidence of safety and effectiveness. Further research is urgently needed. We need to understand how virtual contacts can be used safely, who they work for, and when and how. In the meantime, let's get back to what we know works as quickly as possible. The research is showing us that there is significant increased need in parents who have experienced becoming a parent during the pandemic. Need has soared. If we are to meet this need, then all services need to work together as a system, and all parts of that system need to be strong. The Comprehensive Spending Review is an opportunity for the government to achieve its ambition to level up and build back better following the COVID-19 pandemic, by addressing widening health inequalities and ensuring that parents and their babies and young children are at the heart of policy making. The government's recent early years review documents widely shared concerns that many families currently face a postcode lottery of support, with many missing out as their needs are not identified and care is fragmented, inadequate and complicated to navigate. This represents a significant missed opportunity to improve outcomes and reduce inequalities, which start early in life with cumulative effects and disadvantage which can pass from one generation to the next if left unaddressed. Health visitors are part of the solution. And as part of our ask for the spending review, we would value all of your support in our ask for reinvestment back into health visiting. We know a robust home visiting, health visiting service as part of an integrated system works. We need to build back our health visitor numbers because health visitors are a critical part of the chain for achieving good family wellbeing.
Well, thank you for listening. I hope that was interesting and the views.
Thank you so much, Melita. We now move on to our next speaker who, oh, hang on, my screen has frozen. Can people still hear me? Just anybody make a noise?
Yes, yeah, we can hear
you. Oh, okay, fantastic, thank you. My screen froze. Anyway, sorry, so moving on with our Futures Roundtable, we now have Maria Bavetta, who works for the Maternal Mental Health Alliance. Maria supports the call that every woman in the UK should get the mental health care and support she and her family needs before, during and after
pregnancy. And as part of the senior leadership team, Maria manages a lived experience champion network and works closely with 100 plus people or organizations within the MMHA, which is 100 plus MMHA. She has sat on the Health Education England Perinatal Mental Health Advisory Group and NICE Guideline Development Group for Antenatal and Postnatal Mental Health. And she co-founded the charity Maternal OCD. Over to you, Maria.
Thanks, Ranjana, and thank you for having me here today. I'm just going to share my screen. So yes, I'm here from the Maternal Mental Health Alliance, and I'm going to be speaking about our campaigning work. And you spoke about us being a 100 plus organisation. Sorry, there we go. And we're focused on one thing. And that one thing is the mental health and well-being of women and families and how they can be supported. And we do that by a blend, and I've heard the word blend quite a lot this morning. And our blend is real life experiences, clinical and professional expertise, and that comes from our 100 plus member organisations, our real life expert by experience champions, our staff and our trustees. And hopefully you can see there's a real richness to our member organisations, and I know that some of them are in the Zoom room today, which is wonderful to see. And we're unified to ensure that there are services there for women and families. And at the beginning of our campaign life, if you like, we were given funding from Comic Relief, and that was to look at specialist perinatal mental health services, both community and inpatients. Some of you may have seen these maps. In 2015, there was a RAG-rated map looking specifically at specialist community perinatal mental health teams. Over 50% of the UK had no access to perinatal mental health care. As we go through the years, you can see that the map is changing. And then you can see that approximately 80% of England would have met the green criteria for CCGs. We weren't able to do any more validation because of COVID. Wales, you can see, was red, and it starts to go to amber, and there's a little bit of amber and then green, and I know it's had a bit more funding. And then with Scotland, it's had an injection of £50 million. And then although Northern Ireland, you can't see a change and it's just red, and there's a little bit of Belfast there that's amber. The reality is that beginning of next calendar year, there will be specialist community perinatal mental health services across all 5 trusts in Northern Ireland. So that's good. But still, comprehensive perinatal mental health care is not equal. And if we think about the mother and baby units across the UK, when we first started the campaign, there were 125 beds, and there was a shortage of 60. And 60, as we all know in the room, that's not 60 women and families, that's far more than that. And that came from the NSPCC spotlight in perinatal mental health. If you fast forward a few years, there were 4 new units in England, and you can see south of Wales, we have an interim unit. So we need that to become permanent. And we also need a good accessible option for women in the north of Wales. And in the whole island of Ireland, there isn't a mother and baby unit, although it's promising. In Northern Ireland, we have support from the minister, and we're having a business case that's being written. So it's looking promising. We may get one in Northern Ireland. With all of those extra beds, we now have 169, which means the shortage is only 14. That's good, right? 14 is good. But again, that is still more than 14 women and families that are not able to access this inpatient support. And we're going to have to think about where these beds are going to be located. Is it in existing units? Is it in a new location? Let's think about accessibility. And we're talking about the pandemic today. We can't talk about maternal mental health without thinking about the pandemic. So we commissioned the Centre for Mental Health to conduct a report, Maternal Mental Health During the Pandemic. And look, it was obvious. There were and there are enormous challenges for women and families and for the workforce to support them. And we've got quite a long list of recommendations, and you can read them in more detail on the website. But there's 3 here in particular. One is that ministers need to stand up and be counted and make sure they protect and enhance those services. And I just want to take a moment to really acknowledge the support that the voluntary sector groups provide. It's absolutely vital that they are supported to do that in a really sustainable way. And we've spoken today about the need and about the level of demand. Well, that needs to be reassessed because we know that it's got higher. And we've spoken about research today as well. So there's a lot of synchronicity happening this morning. And when we do look at that research, it's the ongoing impact. Paul, I think you said we can't really say we've gone past the pandemic. No, we can't. So actually, what is the impact of the what's the ongoing impact? And especially on women and babies of colour and those from disadvantaged backgrounds. But I would like to take a moment to really acknowledge our workforce. Melita, you spoke about support that health visitors need, and in fact, before the pandemic, and you mentioned this, there were gaps already, and this isn't a finger-pointing exercise. Our workforce were and are working tirelessly to provide for our women and families. Then we've had the pandemic, and it's taken its toll. So we must, and it's a word that I don't use very often, but we must protect our workforce. We have to look after them so they can look after our women and our families. And so I've spoken about the comic relief funding. Now more than ever, women actually need more support. And this is where we've launched our new campaign, Make All Care Count, and right in that centre are women and families. And around the edge, you've got some jigsaw pieces. Now, these are 8 essential services, and these are, you can see, I won't need to read them out, and each one supports a woman and family, provides services for women and family, and signposts. So again, you spoke about the chain. It's not just how that individual service works, it's how they work all together. Now, I mentioned the specialist services at the beginning. And what we do on the website is actually look at drilling down and seeing what each service provides. Now, I know this is too detailed to read now, but you can go on the website and look at it. But what we're clear about at the Make All Care Count campaign is that 2 things. One is that we're clear, obviously, specialist services can't provide for every woman and family's needs. There are thresholds. So we need all of those 8 essential services that support women before, during, and after pregnancy. We do know that they're a foundational building block. So we know that access to comprehensive perinatal mental health care, it's not equal. We know that action is needed, and that action is that these essential services, they need to be commissioned, they need to be funded, they need to be resourced, and we absolutely commit as an alliance. We'll be releasing resources to help identify those gaps, look at the impact that it has on women and babies and families, and we will continue to shine that spotlight. I want you to really imagine a spotlight on women and families and professionals, and I appreciate we're all here singing from the same hymn sheet, but I think we still need to repeat the fact that we've got to look after our workforce. And so if I think about what we're calling for, the magic word is all. Only 3 letters, but it means so much. And actually the main thread I've heard throughout this whole morning is how we are inclusive and creative of providing for our women and families. So all women and families across the UK to have equitable access to comprehensive, high-quality perinatal mental health care. But that is including and beyond specialist services. And if I look at that list there, it talked about a well-equipped workforce. So I think about the plane analogy, when you're in that plane and the oxygen mask comes down and we put it on the parent to help the child. Actually, we need to put it on our workforce, so we look after our workforce to then support our women and families. Again, the all word comes in. We need care and support for all women, those impacted by inequalities. And if we think about those services for specialist services, they must meet the national standards. And when I spoke about that foundational building block, we know from our research that the services that are specialists act as a catalyst within the wider system of care. So it is all of those 8, but we must remember each one is just as important. I'm conscious that we've done a lot of talking today, so I'm just going to finish with, if you do want to stay in touch, please do let me know and get in contact. I'd love to contact, and I've spoken to some of you on the DMs in the morning to find out some more. And then I'll hand back to Ranjana and Paul to go to the next speaker and look forward to the Q&A.
Thank you so much, Maria, and that was really powerful what you said about we need to look after people who are looking after people. We need to care for those who are caring, and for drawing our attention to the gaps that sort of were there before COVID hit and that were worsened with the pandemic. So moving on now to our next speaker from Fathers Network Scotland, Chris Miasaitis is co-director of FNS. He's spent 20 years working in a variety of public and voluntary sector roles, developing and leading initiatives aimed at improving outcomes for children and family services within a wide range of settings, including the NHS, local authority and third sectors. More recently, Chris has helped to ensure that paternal mental health is a priority and on the agenda within Scotland's National Perinatal Conversation. So over to you, Chris.
Thank you, and thanks so much for inviting us here to talk today. It's been a great morning so far. I'm just going to quickly share my screen. Okay, so yeah, I'm Chris Miasaitis, co-director at Fathers Network Scotland, and our main purpose is to improve outcomes for children and families through the improved service engagement with fathers, partners and co-parents. Okay, so we've known for a relatively long time now that along with witnessing a traumatic birth, a prior history of poor mental health, the ill mental health of a mother and many other indicators, the life transition to parenthood itself can be one of a number of reasons why fathers, partners and co-parents are at an increased likelihood of suffering from poor perinatal mental health. And some of the stats are up here on this slide. But what information do we collect about fathers and partners? What do we know systematically and what don't we know? How do we or don't we interact with fathers and partners during the perinatal period? Not just systematically, but also in our day-to-day approaches. When it comes to the support of a father, partner or a co-parent, the more supported a mother feels, the more confidently she'll be likely to parent, the more her own mental health can be supported. Poor paternal and partner mental health, as we know, can have a detrimental effect on the mental health of mothers and of infants and on family relationships. And the physical health and well-being of a partner is closely associated with the physical health and well-being outcomes of mothers and infants. So a 2018 nationwide study conducted by the Fatherhood Institute with a little help from us up here in Scotland showed that almost 100% of first-time fathers attended at least one antenatal appointment, scan or were present at the birth. So this survey told us that this early period of life as a prospective new parent should be a golden opportunity to engage fathers, partners and co-parents because they're here with us and present within our universal perinatal settings. Mums also tell us that the support of their partner is crucial, and in fact, a partner's support is the most important to them. During COVID, we've seen how enforced restrictions in maternity wards and other perinatal settings have impacted on the emotional well-being of mothers, on their partners, and how it's hampered the nurturing, supportive environment that mothers, infants and families want and need most at this time. So prior to COVID, this survey also outlined that too many fathers and partners were not or could not recall being engaged directly by staff, even in the most basic sense. So sometimes not recall being acknowledged at all during an antenatal appointment that they attended. So the golden opportunity, as it were, is too often being missed. And COVID's clearly made any engagement even more challenging. And even less fathers were asked or could recall being asked key questions about their physical and mental health and well-being, indicators that aren't just important for him, but also crucial in terms of outcomes for mothers and infants. So we're all familiar across a broad spectrum of universal and specialist services that a whole family approach to service delivery, placing outcomes for a child at the centre of our practice is how we must work. But do our systems, processes and approaches determine who that whole family is? Or are they set up so that we sometimes inadvertently decide who the family is through the active systematic inclusion of some and the unintentional passive exclusion of others. The evidence, unfortunately, points clearly to the latter. We are too often guilty of limiting positive outcomes for children and infants through our systematic passive exclusion of fathers, partners, and co-parents. So we all need to look at every aspect of the delivery of our entire perinatal service and beyond and ask ourselves, what part of our delivery is set up in ways that encourage good whole family approaches, and what inhibits good whole family approaches, and how can we change that? So where we are not systematically engaging with fathers and partners, we must move from a place of passive exclusion towards one of broad, active inclusion. And make no mistake, what we're talking about here is a culture shift, societal and organisational. And as public services, we've got a duty to take a proactive lead in shifting the culture forward. We're all, and especially today, we're all trying to turn the oil tanker around. And we can do that if we continue to take the right key steps and to spread the good practice that's already happening that we've heard about today across the UK in a universal way. Fathers, partners and co-parents must be seen as service users in their own right, not just as mother supporter. We must ensure that fathers and partners are supported to understand a mother's mental health and their own, to know what support's available to him or to her, and how he and she can support themselves and support their partners and mothers during this period. To understand how his or her role impacts on child development, and to have the confidence to be that supportive parent that they want to be. So how do we do this? Well, some specifics. Mental health screening across the UK should be a universal offer to all fathers, partners and co-parents, not just those who partner a mother who's been referred to a perinatal mental health support service. In Scotland, for example, no father or partners offered this screening, so we are quite far behind England in this respect. Access to peer support opportunities such as the Dad's Matters project, for example, in Greater Manchester and beyond, should be universal. Key information should be designed and directed specifically for and to partners. It's already been mentioned today, but antenatal classes should be an opportunity to have realistic and honest discussion about just what to expect, what might happen once a baby's born, how relationships and how individuals can be affected and how they can get through that. We must also systematically collect key information about partners and fathers and measure ourselves against that information. Policy, publicity and discussion at all levels should use language that is inclusive and representative. Maria earlier mentioned the £50 million investment in Scotland in the last year or so. That's true, it's happened. A number of third sector applications for this fund to work with fathers specifically were submitted. None were successful. But really, it shouldn't be that difficult. Simply put, what we need to do is to ensure that we improve practitioner and service knowledge on the issue itself of paternal mental health, partner mental health, and father inclusion. We need to improve practitioner and service confidence in dealing with the issue of partner and paternal mental health. We need to affect practice and service change, ensuring that the issue of paternal and partner mental health and of father and partner inclusion is better supported and accessible across services. If every one of the tens of thousands of staff across the perinatal spectrum and beyond instigated just one small change to their practice that made it more father and partner inclusive, then collectively, that's where we'd see that shift forward. That's where we'd see the culture change. Well, we've already heard a great example from Kathleen Kelly a few minutes ago about how fathers can be engaged proactively, a great example of good practice. At Fathers Network Scotland, we believe that workforce development's key then. We've trained over 1,500 perinatal staff over the past couple of years, and demand is increasing, as you can imagine. Staff on the front line, in the middle and at the top must all be given the time and space to reflect on the evidence, on their practice, on their policy, and on the responsibility as individuals and as services to change, adapt, and adopt good practice, policy and systems. We've already heard much of it today, but so much good work is going on across the UK. So let's get to a place where every family, every parent is universally engaged and actively included at the start of the parenting journey and beyond. So follow, please, the Paternal Mental Health Alliance on Twitter. Find out what a group of us are doing and are talking about in relation to this subject. And if you have the time, take a look at our website, the Fathers Network Scotland website, for information about how we and colleagues across Scotland can help you to achieve this goal. That's me. Thank you.
Thank you so much, Chris. And once again, like our previous speaker, there was that sort of really key takeaway there around sort of, I found that really powerful, that slide and the phrase you had on from moving from passive exclusion to active inclusion. And that is really so key. And once again, it's really coming through kind of clearly across all the talks, how these sort of pre-existing gaps, pre-existing blind spots, sometimes passive exclusions, were sort of carried into the pandemic in a way. And these are things that still persist. So I think we might hear a bit more of that actually now from our next speaker, Elizabeth Duff, who has held the role of Senior Policy Advisor at NCT for over a decade. And she's formerly had posts as editor of the Royal College of Midwives Journal, Communications Manager for the International Confederation of Midwives, and Executive Director of Midwifery Trust. And in 2015, she was invited to become a member of the National Maternity Review in England on behalf of NCT. And she now helps drive implementation of the resulting Better Births policy. And I could go on about Elizabeth, but I'm going to hand the virtual floor to you now.
Hello, good afternoon. Hope everyone can hear me. Thank you very much for that introduction. And I'm feeling somewhat daunted after finding at least 3 very hard acts to follow in this panel, never mind dozens of excellent people speaking earlier on. I will now share my screen and hope I can find the right bit. Yeah, that looks all right, I hope. I'm going to talk about postnatal care, which is something I feel very strongly about and I've talked about a lot, and will probably have to be dragged kicking and screaming away from my presentation now in order to allow some time for discussion further on. There's a huge amount to say about postnatal care because it was pretty dire before the pandemic. It was absolutely appalling in the pandemic, and so far as I can see, without further radical action, it's going to stay being the poor relation or the Cinderella service, term often used, of maternity care, and almost entirely ignored in work around early years or even the first 1,000 days. Although in my view, I think when you're talking about the first 1,000 days or perinatal, the perinatal period, postnatal care is right in the middle of it. It is the bridge from the maternity care into the rest of life as a parent. And it is one of the most important. We will see, I hope, from my slides, just how important that is, although I'm sure I'm addressing a very knowledgeable audience here. Just before I move on to my next slide, perhaps you want to just sit back a couple of inches from your screen because I'm obviously doing something slightly wrong.
I think, Elizabeth, you just need to put it on slideshow. So once you go on screen share, right. You need to do the slideshow mode.
And
so slideshow, view show, or start, or whatever first option it is. I think slideshow.
And I should be there.
Yeah, click on slideshow, and then there should be from beginning. Yeah.
Okay. So we're right. I'm wasting my time and yours, unfortunately. Let's try again. My title is I Didn't Know What Was Normal, very often said by new mothers and parents, all together, all parents. This is what we have. This is why I said stand back from your screen. It's not particularly pleasant picture, but it's one that is very often visited on our NCT website, because some parents in the first few days with their new baby at home or even in hospital are horrified by the colours that come out in the baby's nappy. This yellowy green phase, I think it's about 3 days old, is exactly right. This is healthy, but it may previously have been yellow or brown or black or have blood in it. And some of these changing colours can be terrifying and worrying to new parents. I'm not to go on about nappies, and I'm not even going to go on about babies, because my concern is the parents and particularly the mother here. But this is just an example. It's very simple to explain to parents that nappies in the first few days are going to change colour and look odd. They just need to know that, and then that anxiety can be cleared away. I would like to see on our website and on other websites a similar series of pictures, because women also have fluid loss, and I think a series of pictures of mothers' sanitary pads might be very instructive, and so they know what's normal about the loss that they're experiencing there, the blood and fluids that come out after a birth. It won't be popular with some people to have those sort of pictures, but actually, again, something simple could show and reduce anxiety again. Talking about postnatal care and particularly the mental health aspect of it, a lot of you may know Holly's poetry, and I think this short poem actually enshrines a lot of what was happening. A lovely but healthy baby, they're all beautiful, so of course they're beautiful, is brought home, and lots of people admire the baby. The mum is saying, my body's wrapped in silence now to lie and weep and bleed because she is not feeling right. And this is backed up, and again, I don't really need you to read everything here. You can see these are quotes from fairly recent bits of research, partly by the RISK project, where NCT was part of that very important piece of work, and lots of accounts from women who'd had babies during the pandemic. The top one of these refers to a woman suffering a lot of anxiety and not being able to get the care she needs. It does refer to a health visitor here. I have huge sympathy with all health visitors, and of course those who've been speaking today. It's not their fault that the care was so bad and so depleted during COVID and at other times. But this is the sort of effect that it had. And the second little vignette here is in some ways even more poignant, because it's a woman who had a caesarean section. We have about 200,000 caesarean sections every year. And she was sent, I would say, literally from pillar to post to get her stitches taken out, from the midwife to the GP to the nurse. And also you will see she was given conflicted information about the medication she needed to take. And those little stories, you can imagine a whole story behind them of women just feeling abandoned, bewildered, given either no information about something that should be very straightforward, or conflicting information, which is absolutely horrible. And some of this can be pretty straightforwardly solved, I believe. This is the very hard end of it. This is out of the brief report from Embrace UK that happened. That is, yes, the lockdown last year. I think I'm right. Yes, those are the dates. 16 maternal deaths. A maternal death is always utterly devastating and tragic, and most of them could have been handled better, although of course services were fantastically overstressed at this time. And this is a review of those women who were suffering from COVID. again, repeated messages here that we know 88% were from Black and minority ethnic groups. 4 of the women died by suicide. They left a total of 30 motherless children, which is a pretty thought-provoking statistic when you think this was just a few weeks in the middle of this pandemic, which is still continuing. This year, we've seen a lot of maternity safety reports. Again, I'm not going to go through these in any detail, but I have looked at them all. Very, very few of them have anything to say about postnatal, which I find disappointing to say the least, and actually outrageous. The Hodkinson review, it can be understandable. This is about what happened in a particular hospital. But rightly or wrongly, this has been seen as a review that is putting out recommendations that are going to be picked up nationally. And to my mind, that is unfortunate that it has focused so much on the pregnancy and birth, not looking what we know to be the very dangerous period of postnatal. There is good work going on. Very briefly, from NICE, from PHE, from the RCGP and many others, there is work going on in postnatal care. And I would love to see more of this expanded. These documents need to be looked at, but it is not addressing that whole area of continuity and accountability in the woman's maternity journey. Briefly again, quality services are widely described safe, effective, and parent-centred, or providing a good experience. I've just looked at this and I'm afraid postnatal care fits none of those. All the Embrace UK reports show that postnatal care, unfortunately, is not safe. It is not as safe as the other parts of the maternity journey. We don't know if it's clinically effective. The National Maternal and Perinatal Audit only looks at one item as to whether women have been brought back into hospital. The deaths don't happen in hospital generally, so we are not using this excellent tool of audit to actually find out what's happening to them. And a good experience, I don't think I need to go on about that. A huge amount of evidence shows that postnatal care is not a good experience for mothers or fathers. Again, quickly, let's just never forget the mothers who are invisible mothers because they don't have a baby in their arms and they may be bereaved, they may be very ill, they may be in prison, and their baby may have been taken away by social services. No time to go into all of these now, but those women exceptionally need postnatal care of both physical and mental well-being. They are at extreme and high risk of poor health in both those areas. This is what is needed: safety, effectiveness, which will require more research, as has been said, and a better experience for mothers. I've talked about it being called a Cinderella service, and I have shown this before. I've put out this acronym, Get Cinderella into the Palace. What we need is postnatal action. That part of the service needs leadership that takes you right through from birth to at least 6 weeks and probably more. It needs accountability, so where things goes wrong, we know where improvement is needed. It needs continuity, so we don't have that conflicting information, which is awful for new parents. And it needs equity because, as in the whole of the maternity service, the impact of social inequities is devastating and does lead to more deaths. I've talked a lot about the bad things. I'm just very briefly going to say what NCT managed to do during the lockdown was get people out and about, and this is a bit more of a cheering picture. Those who were able to, when they were not able in any other way to meet up with other parents in the way they would normally do, we had tens of thousands, as you could see, walk and talks in a local park, and so many parents said to us, this was a lifeline, this really saved my life. It was the one day in the week I could look forward to. And the rest of the time I was on my own at home with a baby and no idea what was happening, with little help from services. I'll draw a line there, and I think there's a lot to do, and I think most of you will know it, but there is hope, and look at these cheerful mums and happier babies. Let's work towards that. Thanks very much for listening to me.
Thank you so much, Elizabeth. And what a lovely picture of happy people having a walk in the park. And yeah, the walk and talk groups have come up on Twitter over the course of this period, and it's always been really cheering to see. So we've got just about 5 minutes left now till the end of the event. And I don't know if anybody has any questions. Lots of people have shared experiences, I have too, but obviously please unmute yourself if you have a question and say so. But I had one thing to address to all of the speakers, because you all, whether you were talking about mums or dads, you all spoke about one thing that was coming across really clearly. And that is that there were massive, big, appalling gaps before COVID. And then COVID happened and things got much worse. And in a way, almost it was unsurprising that it got worse, because, I mean, the sector had already been sort of impoverished in so many ways by that point. So my question, I suppose, to each of you is, do you think there are any productive or positive ways in which the pandemic has enabled change? And I don't just, or at all really, mean anything to do with the digital and move to digital and all of that, but largely in terms of these gaps where people's interest and eyes are on the big issues, the big things. Has the pandemic helped draw attention to these things? Has the pandemic helped create a bit of more noise about things, or get heard a bit more? So if you could each take it in turns to maybe just say something about that in the order in which you spoke, that would be great. So I think we begin with Melita.
Has the pandemic drawn attention to families' mental health and well-being? I'd like to think it has. It certainly seems like it's more topical. There's lots of policy, there's lots of conversations, there's lots of meetings, but sometimes I just wonder, you know, am I sat in an echo chamber? And am I sat with people that are talking about it and passionate about it, and how is it landing? But from the research that's been done in relation to maternal mental health, paternal mental health, family well-being, and parents expressing, significant numbers of parents expressing that they're struggling with their mental health and well-being, and that translated into lots more publications. I do think it has shone a spotlight on it, and I think it's a great lever for us. We've absolutely loved working with parents who have come to us with good or bad experiences, that we've been able to influence policy, direction, press, further thinking with. So I think we just need to keep doing more of the same together.
Thank you, Melita. And Maria?
I mean, it's terrifying that there were inequalities before the pandemic, and what the pandemic has actually done is show that actually different women got impacted unequally. So I'm thinking about women of colour, thinking about those from socially disadvantaged groups, those with pre-existing mental health conditions, those living with domestic violence. And what the pandemic has done is just repeat the fact that there is an unequal impact. So if the pandemic acts as a catalyst, but it means that these inequalities can now be just right now be sorted out, and the women and families will be provided for, then okay. But it's a good question, Ranjana, and it's quite a hard one to answer, because I'm sure with everyone in the room today, you hear such desperate stories, and they've got to stop.
Thank you, Maria. And that ambivalence and that nuance is, I suppose, exactly what I was expecting. Because like you say, it's shocking how unsurprising some of the pandemic impacts have been. And it's almost like we know about these gaps and we know about these pre-existing inequalities, and oh, look, they have been exacerbated. Yeah, Chris and then Elizabeth.
Yeah, I mean, I think that what the pandemic has done for us in terms of mental health is that, you know, societally, we're culturally amongst ourselves, we all seem to be talking a bit more about mental health in general terms, there seems to be more of an awareness of how all of our mental health is and how it can be affected. So in a sense, maybe that's a good thing for the sort of perinatal mental health agenda, in the sense that there's more empathy around mental health issues possibly. But training midwives and health visitors, working with midwives and health visitors and anybody else working in the perinatal sector over the past year and a half, it's the emotional impact that the restrictions have placed on mothers, the separation that has been enforced on families, to do with COVID restrictions. It's been soul destroying and really quite traumatic, I think, for staff on the front line. But again, trying to look at it in a positive light, if anything, I suppose it's just exaggerated the issue of just how important the entire family unit is, in terms of supporting them and being supported together. Obviously, not every mother goes through the experience with a partner, but there's that kind of sort of family or friendship group that every mother needs to be able to benefit from. So maybe there's more of a general awareness and empathy again around just how important that is, how important these relationships are across our services, and maybe that'll mean that that culture shift that I spoke about will be a little bit more of an open door. And talking about the sort of unequal impact, I should probably say that prior to COVID, that study that the Fatherhood Institute and Fathers Network Scotland conducted, of the fathers and partners who said that they were engaged positively by services during the antenatal period, the demographic was that those who weren't engaged, so whether it's 30% of fathers who don't remember anyone even talking to them, that demographic demonstrated that the more confident, middle-class, professional sort of type father is the one that we're more likely to engage with. In other words, prior to the pandemic, the fathers that we maybe really need to be engaging with more possibly are the ones that we weren't engaging with. And I can only imagine during the pandemic, again, that's been exacerbated. So sorry, I didn't mean to end on a downbeat note, but it just highlights that inequality again, as was mentioned previously by Maria. So I suppose we need to take these opportunities, take these highlights, and try to make the best use of this window of opportunity that we have where people are thinking about mental health in general terms and relationships and families and contact and all that sort of stuff.
Thank you, Chris. And again, completely agreeing that there's a spotlight now on mental health and families. But then again, there are all these sort of, it's hard. I mean, I don't think there's a yes, it's helped, or no, it's not helped answer to this anyway. Elizabeth, I don't know what you think.
Well, I'm just trying to think of some of the positive, the very few positive things really that came out of it. We did early on perhaps get some stories from parents and about actually appreciating the fact they had fewer visitors. They were, because lockdown did not allow others to come round, and especially crowds of friends who come and admire the baby but perhaps don't sit around and expect to be given cups of tea and so on, but actually not very helpful. And some mothers said absolutely it was lovely to really be on their own with their partner there, at least for a while. Some dads and co-parents were able to spend a bit more time with babies because they were working from home, and so at least they didn't have their commute time taken away, so they were spending more time there. Mums just spent time with babies and got to know them. Some people said it was easier for learning to breastfeed, although others had the contrary experience because they were unable to get face-to-face help with the breastfeeding that they wanted to do. So there's always a balance there. And one should not forget that some mothers, unfortunately, are in abusive relationships where actually being locked down was a very, very bad thing. But there were a few who found it gave them more time with their babies to get to know them, and that was a thin thread of good news. Just again to highlight the walk and talk groups, it's obvious in a way walk in the park is a lovely way to meet up with others, but we did find that dads found it easier, that some mums who might have felt a bit marginalised, who might have felt a bit shy of going into a room with others because they felt possibly they were the wrong colour or the wrong age, or in some way were doing something that wasn't the accepted norm. But actually walking in a park does make those things easier. You can join and then unjoin more easily. You can chat to people. It's not quite so intimate, I suppose, but it's still a fantastic way to meet other people. And then if you wish to exchange numbers, join up, make friends from that group. So just a couple of things learning for us. Overall, not much good about the pandemic. No, it worsened services that were bad, didn't do much for those that were struggling on, and it is terrifying to read about the understaffing of those key health workforces, a lot of midwives missing in midwifery, health visitors under fantastic strain, which is appalling because they are so much needed, and GPs who should be picking up the 6-week check, some of them unable to do it through the stresses and strains of their pressures as well.
Thank you, Elizabeth. And again, that links back to what Maria was talking about the enormous pressures on carers and the need to make all care count. Thank you, everybody. Thank you so much for joining us today. Thank you to all our speakers, of course, and everybody in the audience and everybody who's posted on chat. And this marks the end of quite a few years of work now for me and Paul. And thank you to ESRC and our funders. And my thanks to Paul as well for his work and partnership on this project. And Paul, I don't know if you want to say anything before we say bye.
Just similarly, just a big thank you to everybody that we've worked with on this project, and in particular today to everybody that's been involved in this event. I've found it fascinating, sometimes frustrating hearing about all of the difficulties, but also inspiring, hearing about the variety of like incredibly sort of inspirational things that various people are doing and various organizations are doing. So thank you to everybody.
Okay, bye guys, and we'll put up the link for this, the recording for this shortly. Well, it might take a few days because it was a long event, but it'll be there online. See ya.